on the back row behind those guys. Just to...
Good morning. The committee will come to order. This morning, the committee holds an open hearing on the fiscal year 2016 budget request for the Defense Health Program. I'd like to welcome the Director of the Defense Health Agency, Lieutenant General Douglas Robb. This is your first time testifying before the subcommittee. We're looking forward to hearing how your relatively new agency is operating under your leadership. I'd also like to welcome back three service Surgeons General, Lieutenant General Patricia Horoho of the Army, Lieutenant Admiral, Vice Admiral Matthew Nathan of the Navy, and Lieutenant General Thomas Travis of the Air Force. General, all three of you, I understand, are short-timers, and I understand this may be your last testimony before the committee, but on behalf of the committee, we want to thank you for your years of dedicated service to military medicine in the nation, and wish you the best in your future endeavors. And may I say thank you for your roles over the last decades in terms of meeting the needs of our soldiers and sailors and all those airmen who've worked so hard on behalf of the work of freedom in Iraq and Afghanistan and around the world. And I know that all of you have been intimately involved in so many cases of issues that relate to those who've paid the ultimate sacrifice, as well as those who've paid with a loss of limb, had issues of traumatic brain injury, and you've been intimately involved in all sorts of things on the battlefield, on various bases in the Middle East, and the very important element of transporting so many of these young people from both Iraq and Afghanistan through Landstuhl back here to the States for the best medical care that they could possibly receive. And on behalf of all of our committee, and Mr. Visklowski and all members of the committee, we're extremely grateful for the years of combined service. I said to you before the meeting, you're sort of regarded as the inseparables, and I know that you've been working very closely together, and we admire the whole issue of jointness, but joint dedicated service for that length of time we want to especially recognize this morning. This committee has always supported robust funding for the Defense Health Program to meet the commitment to provide the very best in medical care to the servicemen and women who defend our country. However, we are once again facing the looming threat of sequestration and reduced budgets. While we continually hear about negative effects on readiness and equipment modernization, we also remain concerned about any effects the declining budget may have on our world-class military system, and how it meets your quadruple aim: improve readiness, better health, better care at lower cost. Additionally, as has been the case for the last decade, the Department faces a challenge from the growing cost and long-term sustainability of the military health system. The fiscal year 2016 budget request for the system is approximately $47.8 billion, nearly 10% of the entire defense budget request, and includes the entire Defense Health Program and costs related to military health personnel, medical accrual, and military construction, the latter of which is not included under the jurisdiction of this committee, but we are absolutely keenly interested in that aspect. Once again, the budget request assumes savings associated with several controversial Tricare proposals, propositions that have been rejected by Congress for at least the past 3 years. As a result, this Appropriations Subcommittee has had to add hundreds of millions of dollars to cover the assumed savings. We are interested to hear how these proposals may have been improved from the rejected proposals to garner increased support. Our committee also remains very concerned about the progress on the electronic health records and issues of interoperability between the Department of Defense and Veterans Affairs system. The optics on this matter continue to bother all of us, as 8 years ago we started investing in what we thought was a seamless system. Seems we're far from it. I understand that headway has been made in sharing records in the legacy electronic systems of the Department of Defense, of both of these departments, and that the Department of Defense is currently reviewing some expensive, to my mind, some very expensive proposals for their future system. While it's encouraging to see that we've seen some improvement, it's imperative that the goal of genuine interoperability between the departments is not forgotten as Congress fully mandated full interoperability, and our committee has provided significant funding so that it would be accomplished. Whatever the national focus on problems facing the VA, of course, we hope we never hear of the sort of problems they have that relate to our system. So welcome. We look forward to your testimony and to an informative question and answer period. Now, before we hear your testimony, I'd like to turn to my ranking member, Mr. Visclosky, for any comments he may wish to make.
Thank you, Mr. Chairman. First of all, I want to thank the Chairman for holding the hearing today, and I would associate myself with his entire statement and thank all of you for your service and for what you do for the health care of all of our people in the military uniform. Obviously, our responsibility, as well as yours, is to see how, looking towards the next fiscal year, we can do it even better. And as the Chairman alludes, we continue to have concerns relative to the communication between the Department of Defense and the Veterans Administration, particularly given the Theater Medical Information Program that you run. So look forward to your testimony and the question and answer. And again, thank you, Mr. Chairman.
Mr. Visclosky. General Robb, front and center, good morning. Welcome.
Thank you very much. Chairman Frelinghausen, Ranking Member Visclosky, and members of the subcommittee, thank you for the opportunity to appear here today. I am pleased to represent the Defense Health Agency and present its request for funding of the medical programs for fiscal year 2016. On 1 October 2015, the Department established our nation's newest combat support agency, the Defense Health Agency. I'm proud to be its first director. Our responsibilities are clear: to support the Service Surgeons General and our combatant commanders in the execution of their missions. Much like the Defense Logistics Agency or the Defense Information Services Agency, our responsibility is to offer joint, integrated solutions to the military departments where they make sense and where it provides value. By building a management structure with an enterprise focus, the Defense Health Agency is helping to ensure a medically ready force and a ready medical force, and we are already seeing results. We have used a rigorous and a repeatable business case analysis and a business process reengineering to improve how we, as a military health system, deliver services. We have successfully established 10 shared services and achieved $236 million in savings in just our first year of operation. The budget the Department is proposing for 2016 reflects the improved business processes that the Military Health System leadership team, led by Surgeons Generals and Dr. Woodson, has introduced. The Department of Defense is requesting approximately $32.2 billion for the Defense Health Program. Compared to last year's budget, this request represents an increase of less than 1%. This budget supports the core values of our military health system strategy: improved readiness, better health, better care, and a responsible financial stewardship. As one component of this last aim, the Department has again proposed a series of modest efforts to rebalance the health cost shares borne by the government and the beneficiaries we serve. These proposals ensure the Department will continue to provide one of the most comprehensive health benefits offered in this country. I want to briefly mention the combined threats faced by sequestration. The Department's commitment to quality of care is sacrosanct. In the event of sequestration, we will not allow quality to suffer or place any patient at risk, period. But there are significant negative long-term effects on the overall military health system that can undermine our means to support readiness. We understand the Department of Defense must do its part in addressing the nation's budget concerns. However, it must be done in a responsible and a judicious manner. The Defense Health Agency is part of that solution and will achieve these ends through a responsible management approach. I am honored to represent the men and women of the Defense Health Agency, and I look forward to the questions that you may have.
Thank you very much, General Robb. General Horoho, good morning. Thank you for being with us.
Good morning, sir. Chairman Frelinghuysen, Ranking Member Visklosky, distinguished members of the subcommittee, thank you for this opportunity to tell the Army Medicine story. On behalf of the dedicated soldiers, civilians that make up Army Medicine, I extend our appreciation to Congress for your faithful support. I want to start by acknowledging America's sons and daughters who are in harm's way. Over 141,000 soldiers are deployed or forward stationed. Army Medicine has nearly 2,500 civilians and soldiers deployed around the globe. And this has been a year of unprecedented challenges and accomplishments. Army Medicine trained every soldier deploying to West Africa to ensure their safety. Medical research teams from MRMC, serving with our interagency partners, spearheaded Ebola efforts on the ground in Liberia in the lab by developing groundbreaking vaccines. Our U.S. treatment facilities were certified as Ebola treatment facilities by the CDC. We made tremendous strides in transformation to a system for health on our journey to a high, reliable organization and a model for safety and healthcare delivery. Our soldiers' health readiness remains our #1 priority. We added combat power back to the force by reducing the number of soldiers who are non-available due to health reasons. We also significantly increased medical and dental readiness. We're enhancing health readiness by weaving the performance triad into the DNA of our Army. The MHS review validated our pathway to improve safety and quality care for our soldiers, family members, and retirees. The review showed we are either above or comparable to the best healthcare systems in our nation. The latest U.S. News & World Report, Best Graduate School Rankings, validate using our bricks-and-mortar military treatment facilities as training platforms for our clinicians and administrators. Our certified nurse anesthetist program is #1 in the nation. Our physical therapy program is #5 in the nation. Our Baylor program for administration is #7 in the nation. And our physician assistant program is #11 in the nation. Our programs and initiatives that contribute to our success are further outlined in our written testimony. I'd like to take the balance of my time to discuss two major threats facing Army Medicine today. An ever-changing security environment demands that Army Medicine vigilantly maintain a medically ready force and a ready medical force. The first threat is viewing Army Medicine through the lens of a civilian healthcare system. We owe so much more than that. We're national leaders in medicine, dentistry, research, education, training, and public health. These are all intimately linked to soldiers and our providers' deployment readiness. Our hospitals are our health readiness platforms. This crucial link to readiness sets us apart from the civilian healthcare system. Army Medicine provided the majority of the operational medicine and combat casualty care in Iraq and Afghanistan that led to a 91% survivability rate for our wounded service members. The NATO Medical Center of Excellence adopted our key areas from our 2011 Health Service Support Assessment as best practices and lessons learned. These invaluable battlefield experience permeate our education and training platforms at Uniformed Service University, AMED Center and School, the Medical Education Training Center, and in our medical centers. Any radical departure from our combat-tested system would degrade readiness in an environment where the next deployment could be tomorrow. The second threat to Army medicine is the return of sequestration. Sequestration would have a significant detrimental impact on our patients, our families, and our medical team. Devastating reductions to both civilian personnel and military end strength would impact every Army medicine program. Sequestration would cause the MedCom to close inpatient and ambulatory surgical centers at a number of our military treatment facilities, jeopardizing our ready and deployable medical force. Reductions driven by sequestration would be devastating and very different than our current right-sizing to correctly align our medical capabilities. Our valued civilian employees were extremely sensitive to the furloughs and the hiring freeze in 2013. 2 years later, we still have not been able to replace all of these highly skilled employees. Service members go into battle confident because Army medicine, in concert with our sister services, goes with them. For the past 13 years, when wounded service members on the battlefield heard the rotors of medevac helicopter, they believed they were going to survive. We must protect that system that gave them that confidence. I want to thank my partners in DoD, the VA, and my colleagues here on the panel and Congress for your continued support. The Army Medicine team is proudly serving to heal and very honored to serve. Thank you.
Thank you, General, for your testimony. Admiral Nathan.
Chairman Frelinghuysen, Ranking Member Bisklosky, distinguished members of the subcommittee, I am grateful again for the opportunity to appear before you today. On behalf of the dedicated men and women of Navy medicine, I want to thank the committee for your outstanding support and confidence. I can report to you that the Navy medicine team is mission ready and delivering world-class care anywhere, anytime. Navy medicine protects, promotes, and restores the health of sailors and Marines around the world, ashore and afloat, in all warfare domains. We exist to support the operational missions of both the Navy and the Marine Corps. These responsibilities require us to be agile, expeditionary medical force capable of meeting the demands of crisis response and global maritime security. In this regard, we are staying the course with our strategic priorities of readiness, value, and jointness. Individually and collectively, these mutually supportive focus areas are instrumental in shaping our decision-making, internal processes, and organizational capacity. Our strategy is aligned, balanced, and unified, and I believe strengthened because everyone in Navy medicine has a distinct and important role in contributing to the success of these efforts. By leveraging the capabilities of our patient-centered medical home port, and completing our CONUS hospital optimization plan, we are moving more and more workload into our military hospitals, growing our enrollment, rebalancing staff, and reducing overall purchased care expenditures. We recognize the health of our beneficiaries is the most important outcome, and our systems must be aligned to support this priority. Healthcare should not be a supply-driven or volume-based commodity. It is about patient-centered care and focused on all dimensions of wellness, body, mind, and spirit. We must never waver in our commitment to provide care and support to our wounded warriors and their families. This is particularly true for the treatment of mental health issues and traumatic brain injury. While our present conflicts may be coming down, the need for the quality mental health and TBI care will be a continued need, and we are poised to provide these services now and in the future. We continue to embed mental health capabilities in operational units and primary care settings in order to identify and manage issues before they manifest as psychological problems. This priority extends to suicide prevention efforts, where we train sailors, Marines, and their families to recognize operational stress and use tools to manage and reduce its effects. As leaders, we have renewed our emphasis on ensuring that we focus on every sailor every day, particularly those in transition or facing personal or professional adversity. We know that an increased sense of community and purpose is an important protective factor in preventing suicide, and we must remain ready and accessible to those who need help. Strategically, I am convinced that we are stronger as a result of our work with the other services, our interagency partners, including the VA, leading academic and private research institutions, and other civilian experts. These collaborations are vital as we leverage efficiencies and best practices in clinical care, research and development, medical education, and global health security. The enterprise strength of Navy medicine is now and always will be our people. I can assure you that the men and women serving around the world are truly exceptional and guided by the Navy's core values of honor, courage, and commitment. Of note, I am continually inspired by the skill and dedication of our young hospital corpsmen, many of whom are just out of high school, and whose parents, like me as the father of a teenager, marvel at their ethics and capability, but still wince a little as we hand them the keys to our car. We ask a lot of these young people, and they step up. As I travel and see our corpsmen operating forward aboard ships or deployed throughout the world in the combat AORs, I can assure you, Mr. Chairman, that you and the American people can be very proud of their performance. In fact, of the 15 Silver Stars awarded to Navy sailors throughout OIF and OEF, 14 of those have been awarded to Navy corpsmen. We need to recognize what sets us apart from civilian medicine. We are truly a rapidly deployable, fully integrated, vertically integrated combat casualty care support system. This capability allows us to support combat casualty care with unprecedented battlefield survival rates over the last 13 years, to meet global health threats expediently as we did in deploying labs and personnel to Liberia, that slashed the Ebola testing time from days to hours, and to have our hospital ships, the Comfort and the Mercy, Comfort underway as we speak, ready to get out and about to support humanitarian assistance and disaster relief efforts around the world. We must also understand that our readiness mission is inextricably linked to the work our personnel do day in and day out in our hospitals and clinics, in our labs and our classrooms. Our patients expect a lot of us, and they should. I am privileged to work so closely with my fellow surgeons general, who are equally passionate about continuous improvement and moving the military health system forward as a truly highly reliable organization. These are transformational times for military medicine, the likes which I have not seen in my career. There is much work ahead as we navigate the important challenges and seize opportunities to keep our sailors and Marines healthy, maximize the value for all our patients, and leverage joint opportunities. I am encouraged with the progress we are making, but not yet satisfied. We continue to look for ways to improve and remain on the forefront of delivering world-class care, anytime, anywhere. Thank you, sir, for your steadfast support, and I look forward to your questions.
Thank you, Admiral. General Travis.
Yes, sir.
welcome
Good morning.
again.
Chairman Frelinghuysen, Ranking Member Visclosky, distinguished members of this subcommittee, thanks again for inviting us to appear before you today, the last time together, I might add, and that's a meaningful moment for us. Since 9/11, the Air Force has accomplished over 200,000 patient movements in our AirVac system, including 12,000 critical care patients. The very high, unprecedented survival rate for U.S. casualties once they enter the theater medical system is a reflection of our combined commitment to the highest quality care of our patients. Critical care transport teams were developed by the Air Force in the late 90s and have become the international benchmark for safe ICU-level patient movement, dramatically changing how military operates in a deployed setting. We've adapted that capability to meet the joint staff requirements for intra-theater en route tactical critical care transport of fresh, perhaps under-resuscitated or post-operative ICU-level casualties via rotary and tactical aircraft, many from point of injury. Our medical response teams include rapidly deployable, modular, and scalable field hospitals that provide immediate care within minutes of arrival. The Expeditionary Medical Support Health Response Teams, which is an evolution of our combat-proven EMEDS teams, are now being deployed across our Air Force. They provide immediate emergency care within minutes, surgery and intensive critical care within 6 hours, and full ICU capability within 12 hours of arrival. Because of our experience with EMEDS in support of Operation United Assistance in Liberia, an Air Force medical team quickly deployed and set up the first healthcare worker Ebola virus disease treatment center utilized by the U.S. Public Health Service. Our medical forces, as my partners have said, must stay ready through their roles in patient-centered, full-tempo healthcare full-tempo healthcare services that ensure competency, currency, and satisfaction of practice while fostering innovation. We can't separate care at home from readiness, as what we do and how we practice at home translates into the care we provide when we deploy, and we've proven we do it well. In addition, for well over a decade, we've had a cadre of our best physicians, nurses, and technicians embedded in world-class Centers for Sustainment of Trauma and Readiness Skills facilities, such as the University of Maryland's Baltimore Shock Trauma, University of Cincinnati, and St. Louis University in order to train trauma and critical care transport teams before they deploy. We're now committed to expanding training opportunities for non-surgical
and trauma-related skills to ensure all of our personnel remain ready and current, providing hands-on patient care of greater volume and complexity than we normally see in our facilities. Our first course was recently held at Nellis Air Force Base, Nevada, in cooperation with University Medical Center in Las Vegas, with more than a dozen classes to follow in 2015. This will further expand the system we have in place to identify training requirements and track completion of training events down to the individual. I leave the Air Force in June after 39 years. In the Air Force I grew up in, the operators were primarily pilots and navigators. There are many more types of operators these days as air power is projected through the various domains in very new ways. Air Force medicine is adapting and innovating to better support the airmen who safeguard this country 24/7, 365 days a year. In that regard, Air Force medicine is now focusing on human performance. Our AFMS strategy embraces this, and to focus on this as a priority, we recently changed our vision to state our supported population is the healthiest and highest performing segment of the nation by 2025. This vision is focused on health rather than health care and is connected to the imperative to assure optimum performance of these exquisitely skilled airmen. We have begun either embedding or dedicating medics to directly support missions such as special operations, remotely piloted aircraft, intel, or other high-stress career fields, and we've had a clearly positive impact on these airmen, their mission effectiveness, and their families. Patient safety and quality care are foundational to supporting our beneficiaries in their quest for better health and improved performance. In order to improve safety and quality, we are committed as part of the military health system to the high reliability healthcare journey, adopting safety culture and practices similar to other high reliability sectors such as aviation, something with which we're very familiar. This is a journey being undertaken by healthcare systems across the nation. The AFMS joins with our Navy and Army partners as we transform into a fully integrated system that consistently delivers quality health care while improving the health and readiness of our force. With our vision of health and performance in mind, we're committed to providing the most effective prevention and best possible care to a rapidly changing Air Force, both at home and deployed. I'm confident that we're on course to ensure medically fit forces provide the best expeditionary medics on the planet and improve the health of all we serve to meet our nation's needs. Thank you again for your strong support of Air Force medicine and for the opportunity to provide further information today.
Thank you, General. And before I yield to Mr. Carter, who was first in the committee hearing, this may not be politically correct, but I'm in awe of the men and women that work for you and have worked for you for decades, from the battlefield, whether they're a special operations unit where every person in that unit has some degree of medical training that can look after their brothers, to the transport issue. The things that you've done is incredible, really. And through, I was at Bethesda yesterday, and the patient count is down, but the lives you put back together, and I think the committee recognizes this for some of these young people and not so young, whether it's physical or mental, the things that you do collectively, we're hugely appreciative of. I know we're the resource committee, but we're also very thankful for the things that we've invested in that you've done some remarkable things with. General Carter, yes, you are the general from Fort Hood.
No, sir. No, sir. I know some, though. General Dempsey once stated that we don't walk out on our forward operating bases unless we have the confidence that if we're wounded, we have someone there who can help care for us and evacuate us back to the next level of treatment. As you know, planning and employing echelons of medical care is vital in setting the conditions for our servicemen and women to provide the best possible care for those we put in harm's way. There is overwhelming evidence for how successful our military has been at saving lives in large-scale deployments to Iraq and Afghanistan. I believe that we call that the golden hour. Now, as we wind down operations in Afghanistan and Iraq, how are we transforming our echelons to care of care without reducing the quality of care? We're deploying small contingencies with less medical assets to a lot of new places. Are we able to replicate the quality of combat care we have in places like Afghanistan? Can you walk us through the care our troops would receive if they suffered a critical injury as a result of, say, a vehicle rollover, a range mishap in a place like Ukraine or Romania? Can you speak to the process of establishing and operating echelons of care in areas where we have recently expanded other operations, Africa and Eastern Europe? Are there any constraints on medical resources which could potentially result in us becoming overly reliant on host nations? In other words, does that golden hour extend to small units scattered all over the world? And how do you do it?
Yeah, I'll start, sir, but it's kind of a joint response. When we're looking at this, when we look at what we're doing in Europe, there's a tremendous amount of training that is being done in Grafenwehr and really looking at how do we capitalize on the capabilities that we have in the U.S., but with our coalition partners so that we have a certain standard level of care. We're also incorporating telecapabilities into some very remote areas so that we take expertise care from our bricks and mortar and we extend that through IT systems to get that knowledge to our young combat medics and combat lifesavers so that we're having a larger virtual reach, which I think is very important. We're also looking at medical diplomacy in how do we today during where we don't have engaged conflicts, how do we today help build up the capabilities within our coalition partners so that we have better integration in a certain standard level of care. And then we're taking the lessons learned that we've seen over 13 years of war and getting those back into our training centers to make sure that our skill level maintains.
Sir, your question's particularly germane to the naval forces, which have distributed platforms all over the world, often in isolated places, and may suffer a kinetic or accidental trauma. And so, like the other services, we've been providing all of our basic corpsmen now with TCCC, Trauma Combat Casualty Care Training. The big sea change in combat care now compared to, say, 20 years ago was that our young medics and corpsmen come out equipped to do sophisticated life-saving procedures at the scene of injury to allow some time and to allow that golden hour. And then we've also forward deployed expeditionary resuscitative surgical systems where we have teams now that can carry backpack operating rooms on them. They can carry anesthesia machines and ORs, small groups of 4 or 5 people who could do surgery on this table in front of you if they had to at a moment's notice. The evacuation still remains kind of a long pole in the tent. How do you get people from distributed, isolated places back to the mothership in order to provide care? And we've enhanced that, and I think General Travis can talk about en route care and about the ballet of medevac that occurs between the rotary lift and the fixed-wing aircraft.
Ballet's not a word I would have used, but, no, sir, it's a wonderful question, and frankly, it's a challenge. As we deal with non-state actors in remote places like Africa, you mentioned a few others, certainly the commanders who are placing warriors at risk, I don't care what the service, are hesitant to operate without great medical care nearby. They carry their own organic assets who are extremely well-trained and have benefited from the experience of this war to understand how to provide combat casualty care better than any time in history. A lot of those advances, by the way, have translated to better casualty care in this nation. With specific emphasis on places where the golden hour is a challenge, where there may not be organic capability, or we may not have fixed facilities like we've had the benefit of in Iraq and Afghanistan in this long war. We, in fact, have stood up some tactical critical care evacuation teams at the next level called enhanced tactical critical care evacuation teams. We have teams standing by in Germany, for example, that can get on an airframe of opportunity and carry surgical capability downrange where a special operations surgical team may have done the initial resuscitation, but then perhaps, as Admiral Nathan mentioned, do surgery on an airplane on a ramp. And so these are the kind of innovative things we're having to think about as we deal in very remote areas. I would just comment on, as we pull out of Afghanistan, the three of us have traveled there together, and it became very clear as operations have changed there, and certainly forces have moved. You're right, the challenge to keep that golden hour is tough. One of the things that we've all learned and we're all doing is pushing better capability further forward to where actually you take the care out there rather than trying to get them back. And you still get them back, but the care you put out there, and we learned this from some of our allies, if you put out advanced care to the point of injury, as I mentioned in my testimony, you'll watch survival rates go up as well.
Thank you, Judge Carter. Mr. Israel, and then Mr. Calvert.
Thank you, Mr. Chairman. General Robb, a very specific question about scleroderma research. This is something that I have been working on. You may not have the exact answer at your fingertips, but if you would commit to looking into it for me and getting back to me, I'd be very grateful. I've been involved in the issue of scleroderma research for some time, and it's linked to cancer as an acceptable study area that could be funded under the peer-reviewed cancer research program. It was included in the subcommittee's recommendations last year, but was not included in the final version of our bill. And I would appreciate if you would take a look at this and advise me on whether studying a disease like scleroderma, which is not cancer but is an indicator of predicting cancer, is a worthwhile study area to be included in the PRCRP.
Yes, I'll be glad to do that, and as you know, with our Merthyr Cancer Center and also our relationship with the National Institutes of Health and with their national cancer programs over there, I think we've got a better knowledge that we can go back and see what we can do for you. Yes, sir.
I appreciate that. I will have another question on the second round having nothing to do with this, but I'll hold to the second round.
Mr. Israel. Mr. Calvert.
Thank you. Thank you, Mr. Chairman. Good morning, General Robb, General Horoho, Admiral Nathan, General Travis. First, thank you for all being here today, and thank you for what you've done for our country, and wish you well in the future. The FY12 NDAA required the GAO to study DOD's acquisition of professional medical services. Once the GAO had completed its study, they recommended that DOD develop a department-wide approach or contracting healthcare professionals, and DOD apparently agreed with those recommendations. The FY NDAA required the SecDef to develop a strategy for carrying out the recommendation and execute that strategy. The strategy was required to, 1, identify opportunities to consolidate requirements and reduce costs for professional healthcare staff and services, and 2, analyze using reliable and detailed data covering the entire department the amounts of funds expended on contracts for healthcare professionals. General Robb, I'd like to hear your update on how the DHA is progressing with its strategy for implementing the GAO recommendation as laid out in the FY NDAA. And while you're on that, speaking of service-wide, there was a recommendation to go to a service-wide first aid kit, a standardized first aid kit that had a 5-year shelf life. I understand that's been delayed. I don't know if that's an acquisition problem or not, and there's apparently some additional cost to that, so maybe you could touch on that too. Thank you.
Yes, sir. As far as looking at the consolidation of contracts, that is, again, one of the primary and foundational elements for the Defense Health Agency. And through our shared services and our contracting division, what we are doing for a way ahead is looking service-wide where it makes sense to consolidate our contracts, whether it's in the professional services or whether it's in the hiring of, again, healthcare professionals, or if it's equipment purchases. And what we do is we look at all the different contracts. We look at where there's overlap, where there's redundancies, and then how we can move forward to negotiate, again, a more standardized approach to our healthcare delivery. So it makes it more viable, number one, and then again updated towards what we call a modernization in an organized future. As far as the joint first aid kit, I tell you what, that is a success story, sir. We have agreed upon, all of the 4 services, I think for the first time in my career, have agreed on all the elements in the joint first aid kit. What we're working through right now is actually it's the carrying bag, and we're pretty close to decide what that's going to be. But the equipment, and we're lined up that will be one of our first joint products across the board, that will be issued. And that's key in taking what we call the tactical combat casualty care principles in moving them forward and standardize them on the battlefield.
So, and that kit is a 5-year shelf life. When is that, when do you believe you're going to deploy that?
Well, sir, I'll have to get back to you that, because I know we're working all the contracting issues on that, and as far as the contract being let out, I can get back to you on that. Yes, sir.
Ms. McCullum.
Thank you, Mr. Chair. First to the two of you who have announced retirement, and it sounds like there's a pending one. Thank you for all of your service. Very, very much appreciated. And you deal with families facing tragedy, and so thank you for your care and your compassion as well. And I'd like to do a little bit of a shout out for you, Lieutenant General Ornaro, first woman and nurse to have the position that you have. And I'm sure the doctors in the room will agree, nurses are with us most intimately at the beginning of our life and also at the end of our life. So thank you for your profession. Now for my question. So in your written testimony, you all touched on something I'd like to focus on a little more, and that's the challenges that you face recruiting and training the healthcare professionals you need, from doctors all the way on down, and the highly technical skills that nurse professionals are developing. Because having a highly trained healthcare system is critical for our troops, and it's for our families and for our national security, whether it's a service, men and women, or children such as myself when I was younger, accessing your facilities. And then you have, as Mr. Carter pointed out, the responsibility of battlefield and abroad. So you've got a healthcare workforce that needs to be really flexible, highly qualified, up to date on delivery of care service. But then at the end of many military careers, a lot of the healthcare professionals don't do what you do, retire from the military, they go into the civilian workforce. So it's important that for the Department of Defense to be there to train, right? To train the next generation of physicians, nurses, nurse practitioners, physicians' assistants, the list goes on. And then now with the importance on mental health that we're finally starting to recognize and unfold in total care. And I'm concerned about what I'm seeing happening with our teaching hospitals nationally. You're a teaching hospital as well, too. So could maybe you elaborate for us as a committee, because you're going to impact the health of not only our servicemen and women, but our entire country. What are some of the barriers and challenges that exist right now that make it more difficult for you to recruit and retrain the next generation of healthcare professionals? And looking at the long term, what barriers or challenges do you think in the next 5 to 10 years will impact your healthcare readiness, including what might be going on in civilian teaching hospitals? Thank you.
Well, ma'am, I'll start first. I've been involved in graduate medical education at every level for over 30 years. Currently, we enjoy a fairly robust recruiting and retention in Navy medicine. I attribute that partly to patriotism and an awareness of service to country, and partly to the economy. We always keep a close eye on the economy dial because it ebbs and flows, and so does our recruiting. We have a little more problem in our reserves right now. That's my Achilles heel in the medical corps, in that we have more people staying in, and so that's usually a pool where we recruit from, is people getting out. And plus, the reservists, some of them have sort of spent their time being pulled into a 13-year conflict, being cycled 1 or 2 times, and are less apt to sign up in the combat casualty areas. So we're looking at incentive pays and things like that. So far, the health of our training programs, at least in the medical departments, have been very, very good. We have one of the highest board pass rates on all 3 services across the country. And so I think we're producing fine physicians. I think our nursing programs, and Patty can speak to that better than I can, but so far we have the pick of the litter. We fill our nursing programs very early, and we have more applicants than we have room for. I'm not resting on that laurel, nor do I think that can continue in perpetuity, but currently we think we have a good recipe. I share your concern across the nation with changes, in transformational changes in how we educate physicians and residents in training. Because on the one hand, we've afforded them shorter work hours and more opportunity to rest and read and learn. On the other hand, it's still an apprenticeship-type profession. And many educators, senior educators, are lamenting that perhaps we've overdone it and that we're not giving people enough time at the bedside or enough time with the patients to learn via an apprenticeship. But that's something we wrestle with in the military as well as in the civilian sector. And I think as we come together as graduate medical education review boards to look at the sweet spot for how do we give somebody the optimal time to learn and also the time to be an apprentice.
And ma'am, I'll just add a little bit onto what Admiral Nathan just said. So if we look at it through the lens of where we have concerns, the areas of concerns would be in our subspecialty care, being able to recruit some of those highly skilled professionals from the civilian community into active duty service is a challenge in some areas, so neurosurgeons, cardiologists, in those areas. The other area where I have the biggest concern is that if we move towards sequestration and it impacts our ability to conduct research, that translational research of evidence-based practice at the point of healthcare delivery, and really being able to make sure that that is threaded through every one of our graduate medical education programs to enhance quality of care, and then there's a relevancy for the deployment environment, that's the area where I have concerns. And then that's what makes our graduate programs nationally ranked, is we're able to take that strong research and have it really embedded into the way that we train. When I look at an area, an avenue in which to get more of our clinicians and physicians, one of the programs that Uniformed Service University just started, which is taking highly educated young enlisted service members from all services and actually have them go through a pre-med program, getting ready to go into and be competitive for medical school. And we've seen this last batch, most of the enlisted had GPAs in school of like 3.9 and 4.0, extremely impressive. And so that's another avenue of constantly looking. And maintaining our recruitment and retention bonuses is absolutely critical. And I appreciate Congress's support in that area because that has allowed us to maintain the right skill set over the last 13 years of war. And then lastly, I would just say from a national issue, where I believe if we're going to really look at the cost of healthcare changing, if we don't start educating across all of our disciplines to include engineering schools and building our communities, the impact of health and how we increase that knowledge so that it changes behavior, I don't think we're going to ever bend that cost curve in the way that we need to.
I would only add, and I'm glad General Horoho mentioned the bonuses and the pay equity, and it's not going to be equitable. But the support for the bonuses and the special pays is going to be crucial. I would also add the pipeline is where we get the majority of our forces and the training pipeline. So support for HPSB is extremely important. Certainly medical corps, dental corps, that's a great majority. 80% of our medical corps comes out of HPSB. And so it's very important, and FAP, the financial assistance. So we really do need continued support of that. We're doing very well with a not fully qualified sessions, but our pipelines are strong. The only other thing I'd mention is while we are retaining more, there are some certainly who are combat-proven specialists. Trauma surgeons come to mind, and I'm personally aware of a few who have deployed several times in Iraq or Afghanistan who are trauma czars who would now like to make the transition to the reserves. They're finding that's hard to do, and so we're working through the difficulty now. We'd love to keep those folks on the bench, ready for the next eventuality, wherever that is. So we're taking a very hard look at that, and that may be something that we might need help with from Congress. Thank you, ma'am.
Thank you, Mr. McCollum. Excellent line of questioning. Mr. Crenshaw.
Thank you, Mr. Chairman, and let me add my words of welcome to all of you. Thank you for the work that you do. You know, we here, I guess we've heard in our hearings from all the different services, talked about the impact of the budget has on their ability to meet our national defense strategy. Obviously, you're very important in terms of the well-being of troops. It's just common sense. If you're not well and your family's not well, you're probably not going to be an effective fighter. So thank you for the work that you do. And as the chairman said, and my colleagues agree, I don't think you'll find a group of folks more dedicated to
supporting the work that you do, so thank you for that. I want to ask you about, particularly General Horoho. Last year, we talked about malaria. I'm chairman of what they call the Congressional Malaria Caucus, and so I like to kind of keep abreast of what's going on. And when you were here last year, you said there were clinical trials that were going on, phase 3 clinical trials, and those have been completed now. And I think we all know, we've talked about the fact that malaria has all but been eradicated here at home, but it's probably the #1 infectious disease that our military troops face. I was going to ask you maybe in a minute about when we had the Ebola crisis, how it impacted there. But a big question is, tell us a little bit about, update us. The clinical trials are over, as I understand it. We've got vaccines for typhoid and yellow fever, but we still haven't developed a vaccine for malaria. And somebody said the mosquito is the most lethal animal, insect there is. More people die from mosquito bites than just about any other animal or insect. So it's a big problem, obviously. Tell us what we're doing. Where are we in developing that vaccine?
Yes, sir. Thank you very much. We do have a vaccine that is not efficacious for protection of our troops, but it is what we've seen efficacious for taking care of young children that are exposed. And so I think the power of that is that it shows that we can develop something that does the preventive measures, and so it'll allow us to build upon that aspect of it. We're also looking at the different types of medication that can be used when we look at just the vaccine piece of this, the ability to really reduce the cost of health care. Because if we could vaccinate, it's about $1 per person, vice Malarone, which is about $100 per soldier, and then much cheaper, with doxycycline, and also the compliance piece. So with Ebola, we had 5 soldiers that actually contracted malaria. We believe that it was probably due to noncompliance with the medication regime that they needed. All of them are all doing very, very well, but we continue to invest in that area.
Do you think, will there be a day, you said we can, for children, and I know that it's devastating to children around the world, obviously. Some of the appropriations we've given you in the Walter Reed Research Center, where are we in terms of maybe the next step, not just children, but where it might be valuable, even more valuable to our troops as they go?
I think continuing to ensure that we are aggressively funding and capitalizing on the research and the collaborative research that we have in our research centers in Thailand, and the Navy has theirs as well, to be able to make sure that we are learning from those labs that we have, and that we keep the funding going so that we keep that collaborative partnership with the host nations as well as ourselves. I think that's going to be absolutely critical. And when you look at the missions in which we are deploying more and more to, the threat of malaria is one of the biggest threats, and maybe the #1 threat, about 50% risk there. And so I think in that area is to continue that pipeline of funding.
Mr. Chairman, I got a quick question about, we were talking about pharmaceuticals. This is something that just jumped out at me. I was reading, that from 2000 to 2014, spending on the compound pharmaceuticals, like it just gone from like $5 million to $500 million in a 10-year period, and it was going to be $2 billion in the next 3 years. What gives? I mean, in terms of compound, I don't know exactly what a compound pharmaceutical is, but when it goes from $5 million to $500 million in a 10-year period, and it's still not a great percentage of the drugs, but it's like 20% of the cost. Is that, are we working on that somehow? I mean, what has caused that kind of explosion?
Sounds like General Robb has front and center on that.
I've got that one, yes, sir. You are absolutely right. Currently, our pharmacy, 0.5% of our pharmacy prescriptions now account for, and that's because of compounding. Compounding now accounts for 20% of our total expenditures in the pharmacy arena. And again, you were correct. In March of 2014, the compounding cost us about $42 million in that month. It's $330 million in March of 15. And then right now, so to answer your question, why is this? It's really primarily for two reasons. One, it has been a direct and an intensive marketing campaign by those compounding pharmaceuticals, not only directed towards our patients, but our healthcare facilities, both direct care and also in the network, and our providers. And so they've been actively recruiting folks to go out there and get folks to basically switch over to compounding pharmaceuticals as opposed to what we would call the more traditional. That's number one. Number two, so that's intense marketing. Number two is in December of 2012, an average compounding pharmaceutical was about $190 per claim. Okay? December of 2014, $2,600 per script claim. And so that tells you that the price has gone up, the marketing's gone up, and therefore that's driven the volume up. And so what we have done is over the last, we started to notice this about 2 years ago because our compounding, not our compounding, excuse me, but our pharmaceutical ability to identify the products in our claims, that was a new addition. And so we started to notice that there were products within the compounding pharmacy that were not FDA approved. And so our plan was to, how do we best approach this? And so we've been working together with our constituents, we've been working together with our industry, we've been working together with our beneficiaries and also our providers to come up with a way ahead. Express Scripts, which covers about 70% of the pharmacy contracts in the nation, is also the pharmacy contract for the Department of Defense. And they have in place for the civilian sector a series of basically algorithms where they screen the drugs that come in for FDA compliance and also for safety and efficacy. And the number one priority of the Department of Defense is the safety and efficacy for our patients. So that's one. And the number two is to be good stewards of our taxpayers' dollars. So we, beginning 1 May, we will start to screen those drugs with all the input that we've had from the different focus groups. And that's going to be immediately. It takes 5 seconds. And then if we identify a product within those compounding pharmacies that is not FDA approved, we have the ability to go back and ask the pharmacy or the provider if he wants to change the ingredient or change to a different medication. If he does not, there's also going to be a policy in place where they can request an exception to policy, and that will take about 5 days. Before this, and we've already begun this, is an intensive campaign to communicate to our beneficiaries and to our providers out there in our managed care support contracts that this is the way ahead.
Thank you. I would just say, I mean, that's astronomical, and the marketing part, I mean, if they're more effective, you want to make sure that we keep folks well, but if it's so wildly expensive, we want to make sure that that's the most effective and most efficient way to do that. So thank you.
That is the key. Many of these compounding pharmaceuticals don't have the data to back up the efficacy and the safety, and that's one of the primary reasons that, again, we are focused on screening those products to make sure that they're safe and FDA compliant.
Thank you.
Thank you, Mr. Crenshaw.
Sir, could I just add one comment?
Yes,
Since
sir.
this represents possibly, if unabated, the greatest threat to the DHP budget, the way it's accelerating, we're taking it very seriously. But you will probably hear some groups start to lament the fact that we're tightening the reins on these. Be assured that we are doing this on those that have no proven scientific measure of improved efficacy or clinical application. We would not restrain any pharmaceuticals that we thought, from a cost standpoint, provided great bang for buck. So far, these have not proven to. And so because of loopholes and various opportunities, people have found that if you mix two things together and charge for that, which is called compounding pharmaceuticals, you can charge an exorbitant amount. And the DHA and the others are starting to take this seriously, but this is a real threat to the DHP
So
budget.
just for the record, this has been, we've been aware of this for 2 years. Obviously, it's, General Robb, you're in charge of the cost curve, so it's not new. And just for the record, I always thought compounding existed when traditional generic or traditional drugs weren't meeting the needs of the patients. That's why you did compounding. Is that correct?
There's
Or is this another version of compounding, just for the record here?
It's sort of, you're right.
In other words, there's traditional drugs that you get.
Traditional pills and
But then
sometimes.
when you can't meet the patient's need, then you go into a compound mode.
Right, some of it is for ease of delivery, and many of it is, most of it's for pain. But we've known about the compounding pharmacy for 2 years, but it isn't, the actual astronomical growth in the cost has really only been over the last 4 to 5 months.
Okay.
And then I'd like to add one real quick thing on ESI. One of the things that they are currently doing that will also help not only screen it for, again, approved medications, but number two is they are now currently negotiating cost caps for the medications, and so that we will bring the competition and the price down with the pharmaceuticals.
Okay. I just want to get to Mr. Visclosky. I apologize for jumping in here, but I think we need a little bit of clarification. Thank you.
And if I could also ask a question on clarification on the line of questioning, you had mentioned that what will be excluded are drugs not approved by the FDA. Why would they be approved now if they're not approved by the FDA? Myself, and I'm only speaking from, I think it's insidious when sales representatives are like watching TV for a half hour. You have 5 drug ads, and the physicians I talk to at home, they do. I mean, they know exactly what they're doing here. But if it's not approved already, why haven't we been approved?
Many of these are, a lot of it has to do with, as you know, the FDA in our system exists to, again, to provide safe and effective medications for our patients. Some of the medications, as you know, FDA are approved for use in a certain manner or a certain delivery. Some of them are, but a lot of them are not in bulk compounds. And so that's what happens. They'll take these bulk compounds, which are not FDA approved, but if you use them as individual drugs, they're okay. And so it's actually a very complicated, and that's why we have been working with the FDA to have them look at, give us some guidelines here so that we can move forward. And I think this has been a good relationship, not only with the industry, but with our beneficiaries and also with our providers.
I do appreciate the effort.
Mr.
What I
Chairman.
would,
Judge
Would the
Carney?
gentleman yield for just a second? Isn't part of the reason the people go to compounding pharmaceuticals is that the FDA hasn't reached these drugs which they've been approved? I'm just going to tell you the story. My wife has a problem with an esophageal problem that they have not been able to fix. And the doctor said, well, they have a product that has been approved in Canada, and it seems to be very effective. Go to a compounding pharmacy, and we got that product, and it is very effective. And the only reason it's not on the market in the United States is that FDA has not reached it yet. And so I'm going to have to speak out that at least in my experience, it was quite a life-saving drug.
Thank you, Mr. Carter. Mr. Visclosky?
Mr. Chairman, on behalf of Ranking Member Lowy, I just would want to, for the record, point out that she has long been an advocate of funding for congressionally directed medical research programs, and particularly for breast cancer, and for funds that have been provided for service-specific research projects in labs across the globe. For the record, I would like to introduce 3 questions, if I could have the panel answer them. Most specifically, the question relative to have results of military medical research been incorporated into practice, change procedures, or improvement of care? Appreciate it very much, Mr. Chairman.
Consider it done. Ms. Granger?
I had the opportunity to work with Marcus Luttrell on an issue, and in meeting with him, he talked about some very extremely effective treatment he had at the Carrick Brain Centers in Las Colinas, Texas. They're doing really amazing work with service members that are diagnosed with post-traumatic stress and traumatic brain injury. And I toured their facility and talked to some of their patients. In fact, I sent some that had come to me with problems that they were not getting the treatment they needed. And since they were on a grant and could fill that with active duty military, unfortunately, it's still very extremely difficult for service members to receive treatment there, especially while they're on active duty. During this hearing last year, I asked what needs to happen to make medical treatment by organizations outside of the DoD more readily available to our service members. Director, your predecessor, Dr. Woodson, said that you needed to work out a system to provisionally cover these kind of evolving practices and create more flexibility in the program. My question is, what progress have you made in this regard? Are you any closer to making these services more accessible than you were a year ago? And I've asked for years, I ask how we're going to have the persons to treat all those that are coming home for two of the longest wars we've ever had. And the answer essentially was we're going to grow those physicians, which I knew was not going to service the numbers we've got. So tell me how you've progressed in making treatments like those outside of DoD available.
Yes, ma'am. One of the, what I would call modernization efforts just in the last year that is going to allow the Department of Defense healthcare system, military health system to move forward is the creation, and actually through the support of the NDAA, is what we call emerging technologies and treatments. And so what we have created a construct within the Department of Defense military health system to where we will take these emerging technologies and treatments and take a look at them, and to look at, again, the safety, the efficacy, the data that either shows that there's the outcomes are as either stated and or predicted. This will allow us to stay on the leading edge of healthcare. As you know, the Department of Defense military health system is governed by statute, and as a result, we don't have necessarily the flexibility that some of our civilian healthcare systems do. But this will help us again under what I call a legal framework to be able to do that, and we're excited about that. And if that's one of the things that looks promising, then we'll absolutely take a look at it. Yes, ma'am.
And so that can be looked at now, right?
Yes, ma'am.
You're saying that program
Yes,
already
ma'am.
exists?
Yes, ma'am. We just stood it up. Yes, ma'am.
Well, I would hope that you would look at that, because when I toured and when I talked to the people being treated there, I know, for instance, in strokes, that used to say the first 6 months were just magic. Well, they were treating stroke victims that had a stroke 7 years before and were progressing. So I just think for our military, those that are outside of that DoD could be extremely helpful rather than having someone spend the rest of their lives with some of the injuries they've got. Thank you.
Thank you, Ms. Granger. Mr. Ropersberger.
Yeah, first, thank the panel for your leadership in managing our defense health programs. For the last month or so, we've been having hearings with our military about military modernization, procurement, ongoing engagements. But the need for adequate funding for what you do and the defense health programs cannot be understated. And, as you are well aware, these programs are not only important to our men and women in the military, either post-injury or current injuries, trauma, those type of things, but also the research and medical technology benefits our citizens also. I think, General Robb, I'm going to talk to you about the National Trauma Clinical Research Program. Research into trauma treatment and prevention remains a top priority for the military, but it also has to compete with many other areas of research. And many advancements in trauma care are a result of extensive deployments on the battlefield, and we must maintain that momentum in trauma research. I'm aware of the Department's efforts to create a coordinated, multi-institution clinical research network to advance military-relevant topics in trauma care and trauma systems that will allow the Department to maintain the advancement and skills sets critical to progressing in this area of research, even as our combat deployment decreases. Now, the questions are, number one, could you explain the importance of creating such a network, the value it will provide to maintain military and transversely to the civilian communities, and what role the Department should play?
Yes, sir. I think if you look at the signature advances in this current conflict, or current conflicts, and that is the rapid advances in survivability in our trauma system. If you roll back time to around the 2005-2006 timeframe, we stood up and placed in theater what was called the Joint Trauma System. And that was the brainchild of then Colonel John Holcomb with colleagues from the Army and Air Force and the Navy to do an overarching management of the trauma system in the theater, not just in the OR, but pre-hospital, hospital, and all those folks working together for what we call a seamless integration across the continuum of care. What was just as important during that time was the creation of the Joint Trauma Registry, and that's to collect the data that will back up the outcomes that we were trying to achieve. One of the other things that happened during this conflict was the visiting professor program, where we invited the senior trauma, orthopedics, and general surgeons from around the country to participate in the delivery of healthcare in Launchville and at times in our forward locations. So what we started to do was create an incredible alliance and strategic partnership with the trauma community in the civilian sector. They saw our advances, they saw our data, many of which through damage control resuscitation and damage control surgery have translated back to the civilian sector. Many of the physicians who wore those uniforms in those ORs in the theater were reserve doctors who then went back to the University of Cincinnati, went back to the University of Houston, went back to the Baltimore Shock Traumas to deliver those advancing health cares. Now that same group of folks, because of those relationships that were built during our conflict, they see that we need to continue this. And so what we're seeing, so exactly what you saw is there's a request out there for a research and trauma coordination. And that's where we create, again, one of our lines of effort, Dr. Woodson's lines of effort, strategic partnerships with the trauma community out there, where we also work together in our military healthcare system, working side by side with the civilian healthcare system to continue to advance medicine. They learn from us, and then we learn from them in the interwar years. And that's what I call keeping the pilot light burning and continuing the advances in healthcare.
Can you tell the committee what additional resources are required for FY16 to advance this program forward, and what efforts are underway to program for it in the POM, the Project Objective Memorandum?
Sir, I will have to get back to you on the specific.
Okay, you mentioned Maryland shock trauma. Could you tell me about it?
Well, one of the places, and again, in fact, I will potentially succeed here to the question over here to General Travis, but one of our places where we get great trauma experience is up at Baltimore Shock Trauma. And General Travis, I'll pass it on to you to give the specifics of that.
Yes, sir. Of course, we're very proud of that C-STARS training platform, which provided sometimes just-in-time training, but we have an embedded cadre of folks up there who are not only teaching our high acuity or trauma teams, not just doctors, but nurses, technicians, before they go downrange. They're also now collaborating in a lot of research and have been for years. So the effort you talk about, and we have similar institutions or agreements with Cincinnati, St. Louis, and now University Medical Center in Las Vegas.
That's good, and it's expanding. For the record, Maryland Shock Trauma saved my life, and I'm on the board there.
Yes, sir.
How long has the military been at Shock Trauma with fellows?
Got to be going on 20 years.
20 years at least, and it's been very beneficial.
Dr. Scalia has been incredibly supportive, and
No question.
and he's participated in the visiting professor discussion that General Robb brought up.
Okay, yield back.
I want to put in a plug for those who do the search and rescue, CSARS, too. They do some pretty remarkable, courageous things. Mr. Womack.
I thank the chairman. And once again, I join my colleagues in thanking this distinguished panel in front of us today. And my question will follow the lines that Dutch brought up and a couple of others before me. General Horoho, it's great to see you again. You know, we were talking about the continuum of care, and I believe our country is a great country in part because of our ability from the combat lifesaver all the way through the process to the care and well-being back here in the States and the reintegration of our warfighters back into society despite what has happened to them. General Horoho, you know, because you were the person that introduced this panel to Brendan Morocco. Now, everybody up here probably has somebody from their district who could be that poster child, that example, if you will, of this continuum of care, this ability of our capacity of our country to do what we do remarkably on the battlefield. I can't, and this young man's not from my district, he's from Staten Island. I can't think of a better example of a person who is just indeed fortunate to be alive today because of what we were able to do at the time of impact and the rapid distribution of this young man back through this echelons of care, beginning with I think it was a Navy corpsman that rendered aid to him at the time this happened. And for my colleagues who are that don't remember, this was the first soldier, correct me if I'm wrong, that survived double arm.
Quadruple amputee.
Yeah,
Yes, sir.
quadruple amputee and double arm hand transplant
Yes, sir.
surgery. Help me understand where he is today. Can you update me on his progress?
Yes, yes, sir, it's my honor. Brendan is doing really well. He was one of 7 who received a double arm transplant. He now has feelings in his fingers and his hands. He is doing exactly what he wanted to do prior to the transplant. He's driving, and so he has a truck and another vehicle, and that's kind of his pride and joy right now. But he's down to only taking 1 drug for rejection, which is absolutely amazing. And I think he represents really the impact of a joint system and the impact of taking the best care possible far forward on a battlefield, and then having every echelon of care engaged in that throughout. And then the other thing that I think he's such a role model for is that was the collaboration with the civilian community, with major universities, with research that had been funded years ago looking at transplantation and immunosuppressant medication, and all of that coming together allowed him to be able to have a successful hand and arm transplant surgery. We've got 7 right now that are on a waiting list across the nation. 3 of them are soldiers for face and hand transplants. And right now, face and hand transplants now are considered, it happened this year, part of the organ, as an organ. So now they're on the donation list, which will open that up to many Americans and many soldiers, sailors, airmen, and Marines.
His story, dates back to really, I think, Easter Sunday of 2009, wasn't it?
2005.
Or 2005, and so here we are now, 10 years later. And I just think it's one of the most remarkable things I've ever read about, or and being able to meet the young man in person. I just think it's incredible. Can you help me understand what accounts in our budgeting make this kind of a story possible, so that my colleagues can understand what it is that we're doing and what more we can do?
Yeah, excellent. And so, actually, Matt Nathan just brought up, we have the Affluence project that is now on the second phase of this consortium that is actually started at Wake Forest University, but brings in the best of civilian researchers along with our researchers together, really looking at how do we improve burn care, transplantation, rehabilitative medicine. And that has actually funneled money. Instead of individual silos competing for those dollars, it's actually put it together as a very collaborative group, which I think is a forum, that consortium concept, that will allow us to actually tackle some other major issues that we need to be looking at across the United States. So I think the ability to continue funding those types of consortiums that takes down the parochialisms and groups fighting for the same dollars, but rather targets military relevancy and U.S. relevancy in research that we're trying to struggle and solve the issues for. That has been very, very beneficial. They have just actually developed a mechanism that will stretch out the skin so that it reduces scars after major trauma. They've developed a prototype for skin that is not from the human body that allows it to be grown. And so when we look at all the burn patients that we have out there, and so they have really just advanced medicine light years.
Wow. Thank you, Mr. Chairman.
For the record, could you break down the acronym you referred to? I think I'm searching for it up here, but it's
The
obviously
acronyms,
done some
and it's
remarkable
Armed
things.
Forces Medical Research
Institute of
and
Regenerative
Medicine, thank you.
Okay, thank you very
It takes
much.
a team to get an acronym.
I think,
Sir, just a comment, if you don't mind.
Yes, sir.
Sequestration is a threat to research dollars.
Absolutely.
We try to protect health care as best we can in our facilities. You don't want to close your doors, because if they don't come to see us for the health care, they go downtown to Tricare, to the network, and that costs DOD still money. So with sequestration pressures, things like restoration, modernization, sustainment of our facilities, and research dollars take a hit. And not just the organic research dollars for the military medical community, but also, frankly, some of our partner institutions were impacted by sequestration last time.
General, I can assure you that everybody on this panel hates sequestration, and we firmly agree with you. It's a straitjacket we'd like to get out of sooner rather than later, but we are on the Budget Control Act. The President signed it into law, so we'll try to extricate ourselves in a way that does minimum amount of harm to the important work you do. Mr. Ryan.
Thank you, Mr. Chairman. Thank you for your service. I want to kind of go off of what Mr. Womack was saying about this continuum of care. We sit in a committee hearing like this and we talk about defense health care, and then we'll have another subcommittee that'll talk about veterans health care. And I think I want to understand better on how we can integrate the two and what the transitions are. I was in I guess it was a workshop a couple weeks ago in Ohio. It's called Project Welcome Home Troops, where they deal with trauma victims that are veterans. And there were men and women in there, multiple tours, lots of post-traumatic stress, military sexual trauma. So there was a lot going on there that those folks weren't accessing the VA. And so I want to kind of understand, go back to the front end, if you can, somebody on the panel can explain, what are the physical assessments that are done when you come into the military initially?
One of the things that's evolved, sir, over the past is we now do baseline cognitive studies for people prior to deployment. That was born out of potential TBI and concussion.
What's the physical? Just if.
But you're talking about the mind, spirit.
We'll get to.
You're
I wanna
talking,
know.
sir, about right when they
As soon as they
on
come in,
active duty.
yeah, physical evaluation,
So when they.
health, body, blood pressure, or whatever.
So they actually, through our MEP stations, look at the physical requirements, what their health history is. They do their weight. They also look at, they have a behavioral health questionnaire. The challenge with that is that it's self-disclosure. And DOD has been working aggressively over the last several years to see, is there any tool out there that would allow for teasing out that information, vice having someone self-disclose, because if they desire to come on active duty and they self-disclose, then they make themselves not, acceptable to come in active duty, depending on the type of illness. So it's kind of catch-22. So we haven't found a tool that allows us to tease that out without having the input from our soldiers, sailors, airmen, Marines. There also isn't a national electronic health system that you could go into that record and look at that. So one of the question is we could look at the children of prior service members, but then do you disadvantage them? Because we have their electronic health record where we could pull the behavioral health, but they're going to then be at a disadvantage for those that are recruits across the United States. So it's been another area in which we've looked at. And so we have a different entry criteria for your weight, so you can be weighing more than what you can for meeting the retention on active duty, but once they go to basic, then we work to get them into compliance.
So just not to get very elementary here, but push-ups, sit-ups, how run a mile, like what?
Once they come on active duty.
Once they get on
And they
active
have that
duty.
criteria, but prior to, it really is to see, are you physically and mentally fit, and do you have any legal issues that would, or ethical issues that would preclude you from serving in our armed forces?
I'll come back into this, I guess, on the second round of questions, if we have second round of questions. But, so, the next question is, through the transition. So you're done now. You did 1, 2, 3, 4, 5 tours. Those people who I was with a few weeks ago somehow slipped through the cracks. You know, and I think we all have to take some responsibility for this when there's 22 suicides a day for veterans. So can you walk me through what the transition is? So I'm done, check my gun, my uniform, I'm ready to go home. What's the transition for me as I move out? If I know there's a difference if you sense some kind of post-traumatic stress or TBI, that may put you on one track, but just for the average person who you don't notice anything, is there a transition out of the military that we have
Yes,
in
sir.
place?
So everybody, now, if the system, people may fall through the cracks, but it's designed to, everybody who leaves the service gets an inventory of their health, both their mental health and their physical health prior to transition. It's required. And we're making it more and more congruent with the VA system as we speak. It's not perfectly congruent yet, but it's designed to have as less repetition as necessary or as possible so that you don't have to repeat the same groundwork you did leaving the service once you get to the VA. So the VA has more visibility on what's happening to the separation physicals. During those physicals now, what's been instilled in those histories and physicals is a specific targeting and questioning on mental health issues, challenge, difficulty with sleep, questions about self-harm to yourself or to others. These are designed into the system. Now, it doesn't mean that somebody doesn't fall through the cracks and those things aren't performed, but that is policy. You don't leave the service.
I want to get to Mr. Diaz-Balart just before he has a conflict, but I do want to get...
Are you saying he's more important than me, Mr.
Certainly
Chairman?
not. No one is more important than
He is the chairman of the subcommittee that I sit on.
A Buckeye.
I just make a last point, and then I'll come back. I mean, I think we've got to think through, because I know I've talked to men and women who've gone through this, and they lie. They say, yeah, I'm fine. They know you're going to ask about sleep. They know you're going to ask about, do they have thoughts about killing themselves? They know what the questioning is going to be, and they mislead in the transition out. They've told me this. And then 6 months later, those symptoms are much, much worse than they were when they were actually just kind of fudging, and it got worse. And then here we are. They don't want to access the VA, and now we're stuck. So I want to talk in the next round about what kind of better transition, not just the questioning, but is there a program, it doesn't have to be long, but is there something we can put everybody through to help reduce, this great challenge that we all have? Thank you, Mr. Chairman.
There will be a response to Mr. Ryan. There is a program. There are requirements that Congress has directed that certain things be done, and you're going to be more specific when in response to the next round of questioning. Mr. Diaz-Balart.
Mr. Chairman, thank you very much. I actually, as you just stated, I have to step out. I've been called out for the budget conference.
Or you out anytime, but let's get moving here.
But I will step out. I just do want to thank you all for your service, and thank you, Mr. Chairman. I apologize that I have to run out.
Okay, I didn't know you were leaving. Mr. Capter.
Reclaiming my time. Mr.
Okay, let's get Ms. Capter first, and then we'll get to...
Thank you, Mr. Chairman. Welcome. Let me add my words of congratulations and thanks for the service of Dr. Travis and also General Horoho. Thank you both very much for your service to our country. This has been a very difficult period, and I know you've risen to the occasion admirably. We thank you. The people you've served, most of all, thank you. And the American people, thank you. I wanted to ask if you have today, or if you could provide to the record, the amount of your budget overall that pharmaceuticals now consume compared to, let's say, 2000, the base year of 2000. We've heard today about the compounding pharmaceutical issue rising from 5 million to 700 million. That's really a staggering increase by any measure. And but what about brand name drugs and generic? Do any of you have those numbers now, or could you give us a general sense of how that's increased over the decade?
Go ahead. No, I was going to say, I'll take that for the record of knowing the percentage from 2000 to now.
Right, we can get back to you on that, but one of the other initiatives that has occurred with the Defense Health Agency's stand-up, primarily in the logistics arena, when you talk about generics versus brand names, because of the centralized efforts with our, not only our pharmacy division, but also our logistics division, our actual compliance with using the generic drugs over the brand name drugs, when the choices there, has actually doubled to save money for us. And I can get you the specific numbers, but using the national pharmacy contracts and also using the generics, again, we have greatly increased our compliance through the efforts of the Defense Health Agency, both in the logistics and in the pharmacy division.
I'm hearing the words you're saying, but I'm not completely understanding what they mean.
You ask, my sense is that you were asking, how are we being good stewards of the taxpayers' money with the opportunities and the tools we have, and again, through the modernization and again, the upgrades of our management system that we have allowed. Before we had the Army, Navy, and the Air Force, again, doing a great job, but now we've brought those folks together in a more centralized approach.
All right, General Robb, could you just add, if $700 million is being requested for this coming fiscal year for the costs of the compounding pharmaceuticals, would you expect the brand and generics to be triple that, double that? How large is the pharmaceutical portion of your budgets?
We'll have to take that for the
I'll
record.
have to take that for the record.
It's shocking to me that you don't know the number.
Well, we know that the figure that's bandied about for the next 5-year budget for pharmaceutical costs to the DHP is going to be in excess of $40 billion, just for the pharmaceutical footprint alone.
Right.
And so, and I'll take, I'd asked that I be allowed to come back on the record for the exact number, but we take the gravity of what pharmaceutical costs very seriously. On the one hand, the pharmaceutical advances in this country have allowed people to be treated as an outpatient because of some of the advanced therapies and save tremendous money from inpatient care. And on the other hand, the military, I think, has done a pretty good job of looking hard at efficacy of generic versus brand name costs as they implement the pharmacy copays.
I appreciate the specificity of your reply. And let me ask you this. In the area of psychiatric and neurological health, one of the most difficult diagnoses relates to those conditions. And I have evidence in my district, not in the military sector, but in the civilian, that because of the pressure on the application of using generics as opposed to brand name, many of those who've been diagnosed with very serious neuropsychiatric conditions and stabilized are being taken off their brand name medicines and given generics because of servicers, when the servicers get involved. And I want to ask you, how are you protecting the patients that will come under your care from that kind of decisions by insurance companies or servicers as opposed to doctors? I'm concerned about costs, but I'm also concerned about patient care. And if people are taken off brand name pharmaceuticals when they need them, what happens is it costs you more in the long run because they come back into the emergency rooms if they're alive. So could you address how you, as physicians and medical care professionals, are preventing that kind of abuse of the patients under your care in the neuropsychiatric arena?
So, ma'am, I'll take that first if that's okay, because I'd like to, if I could just expand it a little bit, because part of the aggressiveness that we've been doing when we look at behavioral health and psychological health is to really look and say, how do we decrease reliance on pharmaceuticals in the first place? And then prescribe pharmaceuticals when they're absolutely needed. And so we have actually had our primary care physicians that are trained in behavioral health. We've embedded behavioral health in our primary care. We're using acupressure, acupuncture, yoga, and mindfulness to be able to decrease the reliance on pharmaceutical. We've seen a 50% reduction in reliance in that area. We've seen just in opiate usage, we've actually had we were at 6% for a 6-month usage. We've gotten that down to 2.4%. And when you look at all the other things that come from, relying too much on opiates.
What if they're bipolar, ma'am?
That's, I still believe there's medication that absolutely needs to be used for bipolar. But I also believe part of what is more important is to do a comprehensive and holistic care of our service members or their family members that have depression, that have bipolar, that have other behavioral health issues. And so we do look at, is there a medication that will be able to have the outcome that we desire? Is it generic or does it need to be, the labeled medication? But how do we incorporate all these other pieces to it? We've also used 2 other things that I think are very impactful. We've seen a 50% reduction, actually 64% reduction in inpatient hospitalization by taking our healthcare providers outside of bricks and mortars and putting them in where our soldiers are actually working every day to increase that habitual relationship. And then we increased from 1 million outpatient visits to 2 million outpatient visits, which means people are seeking more care. And so I think it has to be this holistic look, because we will never in the U.S. have enough behavioral health providers to be able to treat all of the conditions that we have and the demand in a stressful world. And so my concern is that we do have to take it from a holistic approach and then look at applying the right medication when it's in time to do that. And so we do now have comparable when they leave the active duty and they go into the VA system. We now have an agreement with the VA where they can use the same type of behavioral health medication that they were on while they were serving on active duty. That is a huge change over this last year.
Could I ask you to please look at the Ohio National Guard study that's been ongoing for several years now?
Yeah, I've got it.
Are you aware of that?
I am. And there has been actually some very good data that's come out of that, of being able to link PTSD, childhood adversity, and then generic variants, and to look at how do those all come into play, because that then changes the treatment. And there's been work that has been done at looking at the lowest rate of psychiatric health service use that in service members, also having that tied to substance abuse disorder, and then saying, how do we then insert our healthcare capabilities so that we decrease the reduction of reliance on alcohol and other substance abuse measures that are there. And I think probably the biggest thing that has come out of that study is when we looked at the same model in civilian stressors were significantly predictive of subsequent alcohol use disorders, while traumatic event experienced during the following combat were not. And so I think when we look at the reserves, the National Guard, I think it's important for us to factor in that piece of their life when we're really looking at health readiness for our service members.
Thank you, Ms. Capter. We're going to have another round in a few minutes here. Mr. Adderholt, thanks for your patience.
Thank you, and thanks for being here. I want to ask about maybe address this to General Robb, but certainly open to anyone. We hear constituent concerns about Express Scripts. And the question would be, what is the DOD doing to resolve the issue before this program is going to be expanded significantly to more beneficiaries?
If we could get the specifics, I am not aware of any performance or customer service feedback at my level with Express Scripts.
Okay.
But I would be absolutely, our folks, again, are absolutely dedicated to, one, either compliance with the contractual agreement, or number two, to address specific customer service needs.
Okay. Well, if we could get with you on that, we do have some concerns and questions that we are getting from constituents about that.
Would the gentleman yield on that point?
Yes, I would yield.
Could I kindly ask whether there is a complaint line in each of your departments for those who are having trouble with the servicer?
Yes.
Well, let's hope we have a complaint line. If we don't, we should establish one immediately.
No,
I'm sure we do.
No, we do.
Mr. Adderholt.
Okay. Let me ask about neurofibromatosis. It's a mouthful, so I'll call it NF. It is, of course, severely debilitating disorder, manifest similar to problems our warfighters struggle with, chronic pain, severe backs, breaks in the bones, wound healing, nerve issue. The congressionally directed medical research program has consistently supported the peer review NF research program since 1996. With this investment, NF research has made considerable progress, from identifying the major functions of the NF genes to developing sophisticated animal models, which are now used in preclinical trials. The Clinical Trials Consortium, the first forum for NF research to collaborate on clinical trials, is primarily supported through the congressionally directed medical research program and its funding, and would not be able to function without its support. The NF community recognizes and appreciates the NF research program and is officially run model of the Defense Health Research Program. To further this success, are there additional opportunities for the department to support a clinical trials consortium in moving closer to therapies for NF and conditions related to this debilitating disorder? Let me just open it up to the panel if anyone could address that.
I don't have any specifics.
I can't give you a specific answer on the offshoots of the NF, sir, but the generic answer is yes, there's always opportunity to widen the aperture of these musculoskeletal and genetically based injuries and deficiencies, diseases that create the problem. And so let us all get back to our folks who are engaged in this research. Now that the research is being collaboratively shared across the enterprise through the Defense Health Agency, we have an entree to be able to do these things jointly as opposed to stovepipe. So I think we can get you a more expedient answer.
Okay, that would be helpful if you could follow up on that. Let me switch gears to Tricare for Life. This year's budget request again includes cost savings through the addition of a Tricare for Life annual fee. Question would be what is the formula or the criteria that would be used to determine who is grandfathered into the Tricare for Life and who will be required to pay for this annual fee?
So that would be my question in the exact formula, sir. We can get back to you on that. Yes.
Oh, and just to follow up, have you considered, and do you have the statistics on the number of retirees that has changed?
Would the gentleman yield?
I will.
We don't have a response. Who's grandfathered in?
I'd have to get back to you on that.
Does anyone on the panel know that?
My assumption, and we'll make sure that it's accurate, is that those that have it today would be grandfathered in, and that it would be the new population that would age into it.
Yeah, but I want to make sure we have that.
I thank the gentleman for yielding.
Okay. And then, like I said, have you considered, and do you have the statistics on the number of retirees that this change will affect?
We can get that for you. Yes,
okay. All right. Thank you. Thank you, Mr. Chairman.
Thank you. To General Robb, we've talked about one of the main cost drivers, which is pharmaceuticals. What are two other cost drivers?
For the military healthcare system?
Yeah, absolutely, yeah.
Well, pharmacy is the big one, absolutely. And I think the other large areas are the execution of our direct care system. In other words, our direct health care.
Let me help you out a little bit here. In your testimony here, you say of the fiscal year 2016, Department of Defense is requesting $32.2 billion for the Defense Health Program. Of this request, nearly $24 billion will support direct patient care activities in our military hospitals and clinics, as well as care purchased from our other civilian sector partners. Surely that's one of the cost drivers. Could you talk to the committee about why that is a cost driver and how we're going to lower the cost curve?
Well, that's precisely so. We're in the healthcare delivery business in the direct care system, which is our brick and mortar, along with our Tricare Health Network, are our two primary expenditures in the delivery of healthcare. So as far as the Tricare bill, as you know, we are in the process of We have put out a proposal for what we call the Next Generation Tricare contract, and there are going to be many of the lines of effort in that new proposal will address continued cost containment in the Tricare network. Some of the advances that we're looking at for our new managed care support contracts, number one is going from 3 regions to 2, which should decrease the overhead, but it will also make it easier for us to transition from region to region. Another area that we're looking at.
Maybe a few more specific here. I do want to ask about the viability of our military hospitals and clinics, but I'm interested in the dollar figures that we purchase from civilian sector partners.
Sir,
Do we have any figures here?
each
You know,
can get you the exact
can get those
figures.
numbers.
But
Yeah.
over 50% of the DHP dollar currently goes to the private sector.
Yeah, and how do we know, for instance, that the money is well spent? I mean, I want to ask about the.
So
I assume that we have the quality of care in our facilities, which I will ask
Yes,
about
sir.
specifically, but how do we know and judge where
You're echoing-
50% of the
Yes, sir.
people go?
You're echoing one of the concerns that was raised during the military health system review. And it was, how do we monitor the quality of the care that we provide or that we fund, we pay for, when we either can't provide the care ourselves and have to send the patient out, or the patient lives in an area where they don't have proximity to a military treatment facility, so they go to the private sector, brokered through the health networks.
So how would you judge, since I know you do a remarkable job, all three of you do, how would you judge the track record of some of these facilities where we make substantial investments?
Well, quite frankly, we don't have the visibility on the quality and the care, other than that we send people to. When we send people outside, we send them to accredited organizations that are Joint Commission accredited, but we don't have the same visibility in the external system previously that we do in our own system.
So it's not only a question of visibility, there's a question of cost, and I'm trying to nail just for the committee here, besides the high spike in pharmaceuticals, is this one of the areas where
Yes, sir.
there's some uncertainty as to what
We're pledged
what the
to-
bills would be?
We're pledged to total transparency on our costs and the quality of our care. And the MHS review, frankly, was a real positive energy source for that. On the other hand, with the folks that go outside, and as Admiral Nathan said, you know, it's a higher percentage go outside, and certainly some of our networks for that care. Number one is they may or may not participate in the voluntary reporting that we participate in, that where you can see the quality of the care you provide. And the same pressures that have raised healthcare costs across the nation certainly impact our networks. So the next Tricare contract, the MHS review and the opportunity to have visibility into cost and quality and safety, that's part of this discussion.
So the aspect that's sort of escaping here is that we don't have a dollar amount, or do we have a dollar amount for what we do on the civilian side for the very people that all of us are?
Yes, we do.
Yeah.
We have-
What is the dollar amount?
I can get that exact number for you.
18.6.
Yeah.
Yeah, 18.6.
Would the chair yield?
Yeah, I'd be happy to yield to the
I'm going
Congresswoman.
to yield to you, sir. The question is, so different states have different transparency models. And so I'm from Minnesota, we have a very high transparency model. Sure do. So I think we could look at some states. I think you would be able to get that information from some states, and the fact that some states provide that, I mean, you're issuing a contract. So, Mr. Chair, as part of the contract, we should be able to ask for that information because many states are starting to provide that now. And I think you have a great line of question there.
Well, let me say just for the record, in your operations and maintenance portion of your budget, price and program, I see a private sector care amount of it says $14 billion? $14 billion. Does that strike a bell here, or is that an accurate figure?
Yes, sir, and I think it's.
I'm not
between
only concerned about the
14 to
figure,
16.
I'm concerned about whether, to you, whether the care that our good people get, our men and women in the military, are you satisfied with the care you're getting for that type of investment?
So, sir, if I could just comment a couple things, I'll put it in big picture
Yeah.
and maybe bring it down. So when we did the MHS review, one of the challenges when we were trying to compare ourselves to the civilian sector was to have transparency of data. So when we looked in the area of perinatal care, only 84 hospitals out of 5,000 in the U.S. actually share their data. And those are the 84 hospitals across the U.S. that want to be the leaders in OB and perinatal care. Then when we looked through the lens of surgical care, less than 10% of the facilities in the United States that actually provide surgical care provide their data. So there isn't transparency of data within the U.S. system, except for certain states that have made a decision that that data is there. So when we look at quality and safety, we're not comparing apples to oranges. When we look at, there are places, Tricare in itself, when they just had the survey of the top healthcare plans in the nation, Tricare actually was the #1 healthcare plan in the nation that just came out of the report, and the second one was Kaiser Permanente. So I think when we look at our service members or family members going into the civilian sector to those pre-approved places, we believe there is a certain level of care, but you can't validate that through. When you look at it for cost, that's a different issue. When we look at any patient, I'll give the best example. When a patient goes out into the civilian sector for physical therapy, they on average get about between 20 to 24 visits. When we look at the same injury and the same type of care that's provided within our military treatment facilities, it's 7 to 8 visits. So you look at the additional cost of those visits, and I think that's what multiplies the cost of care in the civilian sector.
But you'd have to take it as a layperson to say that if you have 24 visits, it must be related to the person's disability or condition, and certainly 24 visits would be better than maybe 7 or 8. Is that?
But not when you look at health outcomes.
Okay.
And that's the most important
Well,
piece. It's not the episode of care.
Let's look at health outcomes.
Yes, sir.
Can you tell me of the 56 hospitals, the 359 medical clinics, the dental clinics that we have, what are the outcomes there? I have an interest, I'm sure members do. I know our civilian hospitals are rated. How are our hospitals related? Anecdotally, of course, from time to time we hear of issues, i.e., you certainly don't want to have a baby delivered where they only deliver 90 babies a year. It might be good to go to a place where they have several thousand. Is there a rating system for our hospitals, and where do we stand if there is a rating system in terms of similar systems for the civilian?
Reporting that General Horoho indicated are exactly what we did the deep dive on last year, to where we know the quality of our facilities, where we do OB and perinatal care, where we do surgery, and what the outcomes are. And
so how are we doing?
Overall, we're doing very well.
Good. So if I could just kind of, sir, put it in perspective, when we compared, and I talked about the 84 hospitals, so that is the best of the best. Our military treatment facilities were, when the Secretary of Defense used the word average, it wasn't average in the sense that we think of average. We were average of the best of the best. And then there were some areas where we exceeded the national rankings, and there were some areas where we had outliers. That doesn't mean that it was poor quality or lack of safe care. It means that we were not in that band of the very best of the best, and we all have plans that we've been working. Every single one of our facilities are accredited by the Joint Commission. There isn't one that isn't accredited, and we have met many of the outcome measures that we've identified, and those that we want to continue improving, because we believe for continual improvement. We've got those plans, and we're monitoring each of those very, very closely.
Yeah, we're on your side. I'm just
If I
saying.
could put a punctuation
Yeah.
point on specifically what you're asking, because this is
Because
what
the NDIA has sort of changed the whole
Yes, sir.
scope of our review and leadership around here. And I just want to make sure that we're getting the best bang for the buck.
And this is why the services are so focused on the next set of Tricare contracts and working with the DHA to get this. Because in a practical example, if you were to walk into my hospital and say, I'm going to have a procedure here, I'm going to deliver a baby here, I'm going to have a joint replacement, can you tell me what % of postoperative complications you have? Can you tell me what kind of outcomes you have? Can you tell me how many people have to be revised in surgery after I've done it? Yes, I can to every one of my facilities. I don't publish it enough, and we're doing that now, but I can tell you that. If I send you to one of our network hospitals, not me, but if Tricare sends you to one of the network hospitals, and you come to me and you say, you sent me to Hospital X, okay, I didn't, Tricare did, but we don't do that here, so you have to go to Hospital X. Can you tell me what Hospital X's percentage? I cannot. Do you know how they're doing? I do not. I know they are accredited, or we wouldn't send you there. You're going to have to ask Hospital X if they will give you that information, because I can't give it to you.
Well, I don't mean to mix apples and oranges here, but, you know, in reality, the private sector in some ways is way ahead on the electronic medical records, far ahead, apparently, than perhaps what we anticipated between relationships between the VA and the Department of Defense. So sometimes I think I know where I'm going. Mr. Visclosky.
Thank you, Mr. Chairman. I'd like to follow Ms. McCollum's lead and have a couple of thank yous. Annually, there are Tricare proposals that the administration has. I've spoken often that Congress has to step up here and make some decisions as well. But did point out in last year's hearing, General Robb, that I was concerned about one proposal that would negatively impact families that did not have access to a military treatment facility. And am pleased that as far as the proposals that have put forth this year, that concern that was expressed has been dealt with and eliminated. So I do want to thank you for listening to the committee. Also, Admiral Nathan, in the past, I've bitterly complained not about the Navy's commitment to helping people relative to the issue of suicide and mental health, but that the Navy had so many programs, they didn't have one good program. And you have established the 21st Century Sailor Marine Initiative, and that's my understanding. There is some consolidation of programs taking place. So would also want to thank you very much for that. I'm assuming, again, there's more of a focus and fewer programs, if I understand that correctly.
Absolutely, sir. And the programs are now coordinated through Bureau of Personnel Code 17. And so this allows more coherency, removes redundancy, and is an area to capture best practices across the Navy so that we don't have all these green shoots popping up everywhere, and we can standardize the application better.
Appreciate the, again, Navy listening to the committee's concern.
Yes, sir.
General Robb, have a question on the Jacob Sexton Act that was authorized in the 2015 Defense Authorization Act, requiring annual mental health screenings for active guard and reserve military components. Could you update the subcommittee on the status of the implementation guidance for the new requirement, and if possible, an estimate as to when you anticipate it being finalized and distributed?
So I'll have to get back with the specifics on that to you. Yes, sir.
I would appreciate it, and also because it is a new requirement, if you have an estimate for the cost, and particularly if there is a cost associated with the FY16 budget, whether or not you have adequate funds relative to the implementation, if not, if the committee could understand that. Again, I would reiterate that on Tricare proposals, Congress is going to have to exhibit some intestinal fortitude, but would also think that the administration has to do a better job as far as, if you would, reaching out to retired populations, service organizations, and explaining exactly the need and what the implementations are. For anyone on the panel, if I could ask two questions. One, do you feel more outreach and education on that side of this equation is taking place? And additionally, for some of the proposals, obviously there's always cost involved, even if there's longer-term savings. Would the potential cost in the short term for 16 be covered in your budget request?
If we look at the area of billing for services that bringing in civilians into our military treatment facilities, or the billing for ER services, that is going to have a substantial upfront cost. We did the analysis just at one of our major medical centers, and it's about additional 200 people and the additional software that would allow us to do that. And so when you look at that across, 300 and something hospitals, that has a large price tag. I really believe that when we look at how to drive down cost, I think part of what we have to be doing and what we've been doing over the last 3.5 years is we spend right now $1 billion a year just on obesity-related diseases across our healthcare system every single year. And 70% of the demand on our healthcare system is due to obesity-related diseases. And so just by really focusing on the aspects of health in the area of sleep, activity, nutrition, and then focusing on our wellness centers, we've seen 62% of those that have gone to our wellness centers just one time have had a 4% decrease in body mass index and a 15% increase in cardiovascular output. That right there, it saves about $200 to almost $300 per percentage of body mass index. That in itself will allow us to look at how do we decrease the cost of healthcare and then better utilize the systems that we have to be able to provide care.
The additional cost, do you have that included in the FY16 request?
For the, no, sir, we do not. For what just got proposed, because the proposal went forward, but the actual business case analysis was not associated with it, and that those are concerns that the services raised.
If some action is taken for 16, let's be positive for a minute, would you be short some money for implementation then?
Yes, absolutely, sir.
Could you, for the record, give us an estimate of that? Because, again, we have the authorizers and ourselves. I think it would be important if there is some movement to make sure that you can proceed with the proposal. I appreciate that very much. General?
Just to your point about outreach, absolutely. I have personally walked into a room with 200 people that were Tricare for Lifers, didn't know whether I'd walk out.
I was going to say you're here.
And I am.
That's a positive
And what's
development.
interesting is when you explain, that the cost has really stayed flat all these years, and the actual percentage of the benefit that's covered by the fees has gone down when you consider the cost of healthcare. 27%, I think, of the program was covered by fees when it was instituted in '95. Now it's down to about 11%, and that may be a little off. And everything that's been proposed last year, probably even this year, although I can't swear to it, I think gets us to about 13% of the benefit being covered. And then you lay that against what we're really here to do, and that's the national security and the percentage of the defense budget that, for this to be sustainable, that this now eats.
Right.
These are great patriots and Americans, and frankly, I didn't get a single complaint out of those 200. And they got it. They understood it. So.
Which is why you have, I think, outreach is important so people know there's transparency, nobody's pulling a fast one here. Thank you, Mr. Chairman.
Thank you, Mr. Visclosky. Ms. Granger.
Could you just give us an update on the electronic health records? Tell us, do you have concern about the schedule? Do you have concerns about the interoperability with the VA? Kind of a general across the board where we are.
I'll take that one. Let's go to Jay here. So I believe with the effort that we have generated with a partnership with AT&L and also with the military health system in the integrated program office, I believe that we've got a nucleus of folks that have got us to where we need to be as we move forward. As you know, the electronic health record request for folks to submit their bids was closed out last fall, and right now we're in the process of reviewing all those proposals. We should have a selection for the electronic health record vendor by mid to late summer. After that, we will then use, beginning in the fall, we will use the next 6 to 9 months to take that electronic healthcare product and run it on our, what we call our virtual laboratories, to run it, kind of what I call, put it in the wind tunnel and test it, to see how it works both in the garrison arena and also in the operational arena. Then in the late summer and early fall of 16, we will roll it out to the Pacific Northwest, which will be the first region, which will be a tri-service, which will be Lewis McChord, Bremerton, and Oak Harbor. So when we roll that out, then we will take a pause after that. So take just about 9 months to a year to go from IOC to FOC. But we will take the lessons learned from that, take a short strategic pause, and then what we have is we have a series of regions. We basically have 5 regions and 24 waves that we will roll out across the nation, and then it will be about a 6-year rollout plan.
And the interoperability with the VA?
Okay, so the interoperability with the VA, that is again, there are several fronts on that. That is first and foremost on our, what I will call our objectives. As you know, there was a decision made unilaterally by the VA to pursue the VISTA, and then we've made a decision to move forward with a commercial off-the-shelf product that we believe will keep pace with the industry. As you know, 2007, there was only about a 40% use of the ER. Now, as of last year, we're up to 70-80% in the commercial sector. So the capabilities of the electronic health records out there, again, have that capability technology has exponentially risen, and so we believe that's the most cost-effective way for us to move forward and to keep current what we call Generation 4 and Generation 5. It's also going to cost us probably around $3 billion less to go with a commercial off-the-shelf product than it would have been for us to create our own and build our own healthcare record. And now the interoperability piece of it, we have been working hard, both the Department of Defense and the VA. You don't need to have the same electronic health record for them to be able to talk back to each other. As you know, the banking industry is a prime example. The travel industry is another. But what they have to agree upon is a common language or a common data set for them to be able to talk back and forth. I know the Department of Defense is basically on time and on target currently to meet all of those, what we call the ONC meaningful use criteria definitions, and I know the VA is right there with us. And so when it comes time for the 2 records to talk, when they're finished and we down select ours, I believe that we will be there. Now, remember also, the Department of Defense has to talk to the VA, but 50% of our health care is delivered for our beneficiaries in the civilian healthcare system. And so we are also looking at opportunities for us to talk, again, through meaningful use and for common data elements with the civilian healthcare sector with our new electronic health record.
With the gentlewoman, Neil?
Yes.
Yeah, on our committee, we subscribe to the notion full steam ahead. We don't like to hear about pauses.
Right.
The committee has been making this investment since, I think, 2007 or 2008. I think it's, quite honestly, a little bit inexcusable that we're still mucking around here trying to get this right. Chris Muller gave Ranking Member Visklosky and I a very upbeat
Yes, sir.
view of the Department of Defense effort, and I want to give credit to the things that have been done. But, the whole notion that these words may come back to haunt you here, a virtual wind tunnel, there will be a whirlwind of hurt unless we get some progress here. And we will build into this bill, the same way we did last year, some sort of language to push this ahead here. Now, the VA system may be archaic because they have all these hospitals with all different legacy systems, but we have a more optimistic view of what you can do. And so we're counting on you, and I think in Ms. Granger's questions, she'll continue to yield, was a more specific question about what this whole thing is going to cost and the timetable. I know you talked about lower costs. Let's talk about what you consider to be the lower costs for the next couple of years. So is it $11 billion, $9 billion, $13 billion? This committee is interested in how all that money is going to be spent, but we'd like to get sort of a general idea of what the entire cost of this whole thing maybe just for you.
Yes. Yes, sir. Yes, sir. The entire cost for the total life cycle, And that's when you hear that the $30 billion number is through the entire life cycle that runs through FY32. And then the deployment will, so in other words, that includes the sustainment. That includes the sustainment.
Fiscal year 32?
32, that's, in other words, when you look at the cost of electronic health record and also the, which includes the interagency costs for both the DOD and the VA.
On this committee, we're interested in 2017.
Right.
I thought that was going to be the goalpost here. I'm a little bit concerned that where do we get 2032?
Well-
We'll all be dead and buried.
No, the question is asked, what's the total life cycle cost of the electronic health record? And that
Yeah.
was the number I gave you. In other words, the program sustainment of this current, this acquiring of the new electronic health record is through FY32.
All right, Ms. McCullum.
Thank you, Mr. Chair, and thank you all, because we're now going into 2 hours, so thank you. So if you cannot answer my questions and you want to provide more detail, I will take them written later. I want to touch on two things. One, Mr. Ryan started on, but suicide in the force. And we have a lot of troops that are serving on active duty, and then they return home from deployment to military bases that have a lot of support and a lot of structure built into them. My guards, men and women, and reservists are frequently more isolated. They don't have as regular interaction with peers. We've tried to put a lot of community support organizations and that forward to make that happen. But General Horoho, in fiscal year 2016, the budget request has a 37% reduction in funding for Army suicide prevention. So similar reductions are proposed for the Army Reserve and Guard. So I would like to know the rationale behind that, if it's accounted for in a different way in the way that you've restructured the program. The second question that I have relates to sexual assault. My staff had some meetings, and I guess we're going to be seeing the new training programs that the armed services are moving forward on sexual assault. They're supposed to be much better than the other ones, where we don't blame the victim. But my question is, were you involved either in providing mental health and behavior attitudes towards these training programs? Did they actually talk to people who know about mental health and behavior this time? And so do I have something maybe positive I'll be looking at in the near future here?
Yes, ma'am. So I'll take your second question first, if that's okay, and then I'll answer your first one. So in the area of sexual assault, not only has Army medicine and the healthcare providers been involved with it, but I think more importantly, we've had male and female sexual assault victims that have been intimately involved in helping with developing the training aids. We just had a couple months ago a conference, and we've done these periodically throughout the last couple years, where we've had panels where they have volunteered to come and they've shared their stories. They talked about the importance and how males feel when they're sexually assaulted, because we actually have a higher incident among the male population than we do among the female population, and we've seen a decrease in the female population. So the new videos, I think, are really getting out to the heart and soul, so people understand. Probably the best thing that I could share with you is I just received an email from one of my captains, unsolicited, from the field, who said she was sexually assaulted several years ago, and it was actually from her spouse. And she laid out a horrible story of where the system didn't work. And then her ex-spouse got married again, and she then got called to testify in the court because he abused the current. She said it was like a completely different system, and she wanted me to understand that. And she laid out and said that she felt like our victim advocates, that the sexual response coordinators, that she is still continuing to get in care, and she said it is a 180-degree difference in the entire culture. So I believe we are making strides, and it's been an Army effort in that area. We have a long way to go, just like the nation has a long way to go, but I believe we are making strides in that area. In the area of the reduction in targeted just to suicide prevention. I'd put that in the larger framework. We had 230 behavioral health programs. We have decreased those programs to 11 evidence-based programs, and we've streamlined our process for the behavioral health service line. And then we have a behavioral health data portal that looks at health outcomes and embedded behavioral health. So we're rolling out 65 embedded behavioral health programs that are in our brigade combat teams. The reason why I say that is all of that, to include the performance triad that is now going to be rolled out Army-wide, are all part of the Ready and Resilient campaign program across the entire Army. So we're seeing where we could reduce in sort of silos that we had out there to better streamline our programs and our initiatives so that we have an Army-wide program to really reduce suicides.
So would it be a fair assessment a year from now or 2 or 3 years from now that you cut overhead and unnecessary costs that weren't developing in a way that was direct treatment to the soldier? And now what you have is going to be, I mean, you cut overhead and you improved your delivery system?
We've cut a tremendous amount of overhead. We have streamlined our practices. We've standardized those practices. We now have a behavioral health service line that ensures continuity of capability across the force. And then we also use telebehavioral health. And so we do 90% of Department of Defense telehealth. So it's all of those coming together. We've seen a reduction in our suicides. Our trend line has been down. It'll never be low enough for us because losing one soldier is one soldier too many. But I believe part of the direction we're moving is in the right direction.
Mr. Chair, just a quick follow-up. So when you say you're seeing a trend in reduced suicides, that's good, but is the trend in quote-unquote active duty, or is the trend in reserve and guard?
So we've been monitoring. So last year, our Reserve and National Guard actually had a higher number of suicides than our active. This year, we're seeing a decrease in the Reserve and National Guard and a small bump up in the active. So, but overall, the numbers. And so, to be honest, when we are looking at our Ready Resilient campaign plan and our performance triad, we're applying that to the reserves and the National Guard. And we're also using tele-behavioral health for the reserves and the National Guard. So I think it's going to be a close monitoring when you look at life stressors, when you look at deployments, when you look at past, sexual assaults and that of our young service members prior to coming in. Those all come out once they're on active duty, and all of that has to come together to really focus on their psychological health.
Thank you, Mr. Chair, and thank you for your indulgence.
McCullum, good line of questioning. Mr. Ryan?
Thank you, Mr. Chairman. I want to quickly get back to the mental health baseline. Congressman Glenn Thompson and I, in a bipartisan effort, we have the military evaluation parity bill that we are pushing that has a lot of support from the VFW, National Guard, Military Officers Association, American Psychological Association to help create more of a baseline. And I just wondered if we could get your help and support on that. If anyone wants to comment or not.
Just a comment. I think you have to make sure that the effort's targeted right. We're all short of mental health providers. We strive to keep them, but the demand on the outside for what the whole nation is short of certainly draws them away from the military sometimes. So the bang for the buck has to be there in what is now already a very short career field. That's what I would say, sir.
So you're saying we don't have the manpower to
No, sir, I think we just have to make sure we use it appropriately. And for example, the annual face-to-face mental health evaluations may not be able to be done by a mental health professional. And you can do that face-to-face with another provider, assuming you target it right. And we're working, all of us are working on, meeting the NDA's requirement for that annual face-to-face mental health assessment. May not be able to be done by a mental health provider. So I'm just, I guess, generally characterizing what is a very stressed career field already when you think about, and we are involved in sexual assault prevention very clearly. We're involved in suicide prevention very clearly. We're embedding in our operational units where the stresses are high. We've all talked about that. It's making a difference when we're preventing suicides or everything short of suicide, things like domestic abuse, alcohol or drug abuse. There's a whole spectrum of badness out there short of suicide. So our mental health providers are very, very occupied, is what I would tell you. So I think what you're aiming for is very laudable. We just have to make sure it's targeted right, and then it's up to us to execute it.
Okay.
We all want the same thing.
Thank you. That's helpful. General Horoho, did I hear you say 70% of the healthcare costs are obesity-related?
I said 70% of the demand on the healthcare system are related to diseases that have a relationship to obesity.
Right. Okay. That's a stunning number, and I think something. But I know in the one aspect with Ms. Captor's question, when you talked about some of the alternative approaches for mental health promotion with the mindfulness and the yoga and the different approaches, I think to me that's the future of healthcare. That's how we save money. That's how we keep people healthy early on, prevention, so on and so forth. Talk to me about nutrition, because I believe that this is to me seems like a very straight shot. If 70% of the costs are coming from obesity, to me that's diet and nutrition. We don't need to get into pharmaceuticals. We don't get the cost of type 2 diabetes drives this cost up tremendously for us, and I think we're in a scenario here where I think we can play some offense. I know there's a Healthy Base Initiative, and we're working with Senator Mikulski a lot on that. I know she's been spearheading that. So what more can we do from a nutrition? I've walked onto a battleship, and I went into where they eat lunch, and it's not good food that was, not healthy food anyway, that was sitting there. So help.
So I think the culture and mindset is that looking at food as medicine.
Yeah.
And really looking at how do we improve health literacy, because I believe if people understand the why, they'll make better choices. And we are not at all talking diets, nor have we talked diets in the last 3.5 years, but it's really providing your own personal health data and information, and then providing the right structure and environment to be able to do that. So the nutrition is a key component of our performance triad, which focuses on sleep, activity, nutrition, and nutrition also focuses on tobacco cessation. So it's really anything you put in your mouth if you think of the nutritional aspect. We have, across our facilities, we have labeled food now of high performance, low performance, and moderate performance so that they understand the impact of what they're about to eat on their overall performance and health. We've reconfigured some of our dining facilities, and what we found is that if you move your dessert bar from being the first thing that you see walking in, and you put a salad bar there and you put the dessert bar in the back, we've seen actually a 50% reduction on the purchasing of desserts and a 36% increase on the purchasing of salads and other healthy nutrition. Fort Campbell's a great example where they brought in the young children and they have a health garden. And so the Girl Scouts actually grow vegetables and that, and they do it from an education. And then they've taken sodas out of their dining facility, and just in a short amount of time, they actually decreased 600 pounds of sugar being consumed, and it was in a very, or 6,000 pounds of sugar being consumed in a very short amount of time. But they replaced it with different healthy waters, and so I think when we look at this, a couple things, I think from a nation, we need to look at what we're providing in our school systems. I think from a military perspective, we need to look at how do we have better partnerships with the fast food industry, not so that if you buy something that's healthy, it's at the same cost as something that was unhealthy. And we make it easier for our service members to be able to make those types of decisions.
Okay. Mr. Chairman, I think this is a significant
You took a
opportunity
dig
for
at
us.
Navy chow.
Well,
Admiral was sucking it in there for a few minutes.
I've got to, Mr. Ryan.
No equal time here, I guess.
Well, Mr. Ryan, first of all, if you go to a warship or a Navy ship, and you can get a burger there, guilty as charged. But that said, I think you'd be impressed with the initiatives that Secretary Mabus has made with the 21st Century Sailor and Marine. All of our ships now have a healthy choice alternative, especially the larger ships, the aircraft carriers, where food is calibrated. We've turned the serving spoon around, meaning we serve you instead of you just get to take whatever you want. So there's portion control, which is huge. And again, this is somewhat of a third rail subject, but the Secretary is very invested in trying to do tobacco cessation across the Navy. And this is something that I think it may not, I'm sad to say it probably won't come in my time, but I hope it'll come in my successor's time. Because I think if we're going to address the total health picture of the young person today in the military, it has to be the nutrition, as you said, it has to be the mindfulness, it has to be the portion control, and it has to be the tobacco cessation.
Yeah, Mr. Chairman, this is an opportunity for us. I just want to, we sometimes think we want to talk about compounding pharmaceuticals and all the, it's about food. It's about some of the basic stuff. So I'm thrilled that you're into it and look forward to working with you. And that group of people that still go to the dessert, no matter where you put it, Mr. Visklosky falls into that category. I just want all of you to know that.
Yeah, this is on the record, and God only knows that you've done irreparable damage to Mr. Visklosky's reputation. Thank you, Mr. Ryan. You got your time. You reclaimed some good time, though, didn't you? Mr. Rufusberger, Ms. Capter, any additional comments?
Yes, I have
Mr. Rufusberger.
two. I know, quickly, interesting conversation about food. I do enjoy food, and I think one of the things that you're talking about, the serving someone, because buffets are very dangerous, and I think that really makes a difference. So, Tim, I'm glad you raised the issue, and I think it's important. I want to get into something Steve Womack talked about, and that's dealing with our men and women coming back who've had severe injuries. I know I was involved at Maryland Shock Trauma with a face transplant, which took about 10 or 12 years to develop. The people who have to wear masks because they come back, they're embarrassed, their faces are blown off. You know, the issues with hand surgeons, losing legs, paraplegics. I want to talk to you about the issue of peer review orthopedic research program. Now, I strongly support the U.S. Army Medical Research and Material Command Combat Casualty Care Research Program. Did you get that? What that is? Okay. To advance cutting-edge battlefield care that has truly saved lives and helped our military coming back home. I'm particularly impressed by the clinical trials and research data coordination being conducted by a consortium of clinical centers that are studying major extremity trauma for the peer-reviewed orthopedic research program. And it's my understanding that the program itself, the orthopedic research program, and cooperative agreements for this consortium, which were originally funded in 2009. And I worked in 2009 with then, at that point, Jack Murtha, who's no longer with us, and he was very involved and active in that plan, and there were a group of us that worked on it. But I understand that the money's running out for that plan, and it's so important because we have so many of our military who've lived because of the protection of the vest, but their extremities have been really damaged or they've lost their extremities. And I'm really concerned about this program that has so much potential in the future to help our men and women that come back, and we know we owe them to come back, that do not come back whole, and how we deal with them and work with them in prosthetics. I remember an issue involving, at one time you could only use a hook, and now you can literally start, because of this program such as this, you can literally use fingers to do that. And these are the type of things that we must continue to do. And this also helps the private sector too, and the partnership between I keep referring to Maryland Shock Trauma, but I know the Air Force especially working in these programs on research together. So I have two questions. Please describe for the committee the importance of the role these consortiums play in the medical research field. And secondly, would you support additional funding to the peer-reviewed orthopedic research program in order to ensure that this consortium continues and we can help our men and women from the military? Because I understand the money, again, is running out from the original 2009.
Yes, sir. Consortiums are a truly valuable bang for buck. You're correct in that many of these research partnerships are not only from the organic funding this committee so generously provides, but also from grant money that comes from reimbursables from private institutions. When the economy is up, as would be the case for the Mayo Clinic, grant money is up. When the economy is down, as would be the case for them and for us, reimbursable research funds are down. So that's why we're you've heard the unified chant from all of us that we need to maintain an organic critical mass of research funding stream to keep this going. The AFFIRM study, which we've mentioned before, is an example of that. All of us have various partnerships that extend all the way from Southern California with UCLA, in TBI, to the McGowan Institute, through the NICO facilities. And then, of course, the dramatic signature injury of this war, which is extremity loss. And how are we going to approach that, not only from a mental and spiritual fortification standpoint, but from getting you back to normal? Ideally, with prosthetics, moving to transplants, moving to ultimately, at some point, regeneration. That time will come as we get into spinal cord research and other things. So this is very valuable, and this has been sent out before. In many areas, the military gets their expertise in standard injuries and illnesses from the private sector. Diabetes, things like that. We contribute, but the largesse of it comes from that. And as a whole, our society gets the largesse of its trauma capability and rehabilitation from the military.
It's my understanding for Kennedy Krieger, who does a lot of spinal cord research, is working closely, and they feel that if the funding continues, there could be a possibility in 10 to 12 years to start getting these people who are paralyzed from military injuries or any injuries, out of the wheelchairs and the ability to walk. But unfortunately, the money is slowing down. So I guess your answer to my question, because I know we're getting late here, that you're clearly in favor of continuing the funding in the peer-reviewed orthopedic research program.
Absolutely.
For spinal cord, joints, whatever that may be.
Well, let me assure the gentleman, if he'll yield, that there's a keen interest in the congressionally directed funding. I think there's some concern as to whether the new Defense Health Agency, I won't say the chain of command because you represent the top of the heap in some regards. We want to make sure that we continue that funding stream for these very important investments and not get choked down by too much extra bureaucracy. So I can assure you we'll be addressing this issue and other congressional ads as appropriate. Ms. Capter.
Yes, thank you, Mr. Chairman. Very quickly, I'm going to tick off several items. General Horoho, thank you again for your service and for including a title in your testimony, Transitioning from a Healthcare System to a System for Health. I like the way the discussion is going. I've had that very same discussion with the VA and believe I represent the first VA clinic in the country, which we call a VA center, which is turning the old concept of sickness to wellness. And so we thank you for that very, very important perspective. I wanted to also ask Admiral Nathan, could you repeat the number that you gave in my prior question on the cost of pharmaceuticals, what the projected amount is over what period of time, please?
Yes, ma'am, I'm happy to. And this is usually where the public affairs officer comes after me and says what the Admiral meant to say was. But the figure that we're quoted offhand for the FYDP, the FIT-up, over the next 5 years is $40 billion.
Over the next 5 years?
5 years, $40 billion.
I hope the American people are hearing that during this
Now, this is all comers in the MHS. This is prescriptions that are provided within our lifelines in the direct care system, as well as the prescriptions that people pick up in purchase care in pharmacies.
If the gentleman, this is to address the needs of an estimated 9.2 million beneficiaries that are in this system.
Yes, sir.
Families, too.
Yes, sir. Families, too.
Thank you. Thank you for the time.
I want to note that in the civilian sector, as well as this one, obviously, the cost of pharmaceuticals is off the charts. I cannot believe what my constituents are dealing with, as well as the military. And it is beyond reason, and many people simply can't afford it. So it's impacting this budget as well, and I just want to make a point of it. I wanted to also ask, General Horoho, we talked a lot about neuropsychiatric conditions, and I support all of the supportive services that you are providing to your soldiers in the regular force and in the Guard. Can you provide, for the record, a listing, and maybe all the departments, of your inpatient and outpatient services in a year? What % would fall into the category of, however you describe it, behavioral health? I call it neuropsychiatric care. What percentage of inpatient and outpatient visits every year relate to that? And then subdivisions of that. I distinguish in my mind between TBI and between someone who has a very serious bipolar condition. But I'm interested in how you would classify it.
Yes, ma'am. So when we look at our TBI and behavioral health, we've actually made a move over the last 4 years to put those services together, because we believe it's very hard to tease out one from the other. And so what we're finding in our Intrepid centers is that by having those two together, along with neurocognitive behavior therapy, and then the other alternative therapies together, we're actually seeing very good success rate. And we've done that on the battlefield in Afghanistan as well. We used to have them separate, and we put those together. And when we put those together, and followed our protocols, Army, Navy, and Air Force, we actually had a 97% return to duty rate for those that had exposures to concussions. And so, and then we've seen a decrease with behavioral health, because we were, instead of waiting for our soldiers to come back, we were actually treating them in theater and at the point of when something happened. So we're trying to be much more aggressive in treating stressors in life, and then also the whole array of behavioral health diagnoses
Well, I'd be
that are
real
there.
interested in the classification of how you would term these conditions.
Okay, we'll be-
And then what's first, second, third, fourth on the list for each of your departments. That would be very,
We'll
very
be glad to.
interesting. I wanted to also ask General Travis, could you, in the area of human performance, could you elaborate a bit on the concept of human performance and the link of technologies used in missions performed by airmen? And what actions you've taken to create the shift in focus to human performance? What are you finding?
I'll keep this brief, and that's hard because this is something that's a passion, I think, with me and certainly those that I work with now. And it applies across the services, I believe, and we've all kind of acknowledged this today and in our previous discussions. But in particular, RPA operators, remotely piloted vehicles, who now we're projecting air power from thousands of miles away, and you'll have young airmen who are sitting in a dark room with a bright screen with a top-secret security clearance, who are, no kidding, watching people who would do us harm or our allies harm, and making decisions or communicating information to commanders in the field to make decisions that is part of the kill chain. And so these airmen, and 90% of them are very young airmen, are wonderfully skilled, very talented, but they step out of that battle space and they are in battle in places like, Nevada or New Mexico or you name it, Virginia, California. And many, frankly, now reserve and guard units are doing the same thing. We felt compelled and by the need to support these airmen the way they project air power now, and I'm only named those two career fields. We're looking really across the spectrum of how we present air power these days. We now have embedded not just mental health provider and a technician who have top-secret security clearances, but also perhaps a family practice doc, flight doc, and a medical tech also with a security clearance. The line actually paid for these positions, paid for their clearances. I might also add, in two of our intel groups that I visited, the mental health providers also have a therapy doc. And they have space on the floor, they have the right clearance, they are right there with those airmen who now understand that's their doc. And you talk about a way to break down stigma. They don't have to go to a clinic and say, hey, I'm having trouble. They don't do that. They actually know their doc. They actually may talk to them during their break, their mandatory break from their shift. And then if they really do need intervention, other than just the little talk they might have there, they'll make an appointment with them the next day to their doc. Might be 5 in the morning, and they'll get the help they need. By the way, the command chief that works in one of these wings told me that in the past year we prevented 2 suicides in her unit. That tells me we also then prevented or mitigated a lot of other bad behavior that I alluded to earlier, drug abuse, alcohol abuse, just on wellness, frankly, in a very high-stress career field that we now really is how we do war. It's not like it used to be.
One of the interesting findings that we had in the Ohio Guard study was that because we do not have a draft and people voluntarily enlist, that it actually was shocking to me the number of people coming into the military who've had violent experiences in their own life multiple times, and how this impacts behavior inside the military. That is a change. That is a generational change. So I just wanted to put that on the record. And finally, Mr. Chairman, take 5 seconds to say I was going to ask the Departmental Health Service group to let me know what you pay every year for heparin per bag, and Depakote and Lamictal, brand name medications used in neuropsychiatric care. I'd like to know what we are paying for those. They're critical to many patients, and I'm just curious what the per unit charge is.
If you can provide that for the record. Thank you, Ms. Capter. In closing, we alluded to it. In January, the Military Compensation and Retirement Modernization Commission released their recommendations. I assume you're intimately familiar with some of those recommendations, and I guess this is directed towards the Surgeon Generals who are here, and you've had remarkable careers and dedication and done some incredible things on behalf of our soldiers and sailors and airmen. One of those recommendations is the Joint Readiness Command billet. I know that you have a chain of command, but since you've done some incredible things for our nation, what is your view of that recommendation? What are you at liberty to say relative to that recommendation from this rather distinguished group?
Well, sir, I think we're certainly at liberty to say that we are aligned with readiness and the documentation of it, the demonstration of it, and the accountability of it that the Commission is after. The Commission wants to, I think, based on our interactions with them, make sure that we are as ready tomorrow as we have been today. Their mechanism for doing so has some advantages and some disadvantages. All those are being brokered, and this is where I retreat to my fairly politically neutral statement, but all those pros and cons are being brokered, as we said, from our inputs, our service chief's inputs, up to SecDef, who will give his recommendation to the President and then to Congress. But the one thing we have told the Commission that is on the record is that they have our full attention. They already had our full attention when they talk about readiness. You've heard about the interactions we have at shock trauma. The Navy's fully engaged at LA County. The Army is in Tampa, Florida, and we are, as we speak, we are growing our network of interactions with the civilian subject matter experts and robust trauma facilities to make sure that we maintain a corporate expertise and readiness for combat casualty care. We have to be as ready for the mom walking across the doorstep to deliver a baby in Virginia as we do for the soldier who was felled by an IED in Afghanistan or the Ukraine or somewhere else. And so this is job number one to us. So the specifics of whether we need a readiness command to do that or a readiness billet to do that will be up to our immediate superiors in charge. But we certainly commend the committee for their attention to making sure that the military understands its readiness of the future.
Well, you've been remarkable stewards of all of those who serve our nation in uniform, all of those who volunteer, and your concerns and your voice and your opinions matter. I want you to know that the committee feels very strongly that your opinions do matter, and I hope that this isn't the last of your offering your good opinions and professional judgments into the process. Anything further, Mr. Visklosky, before we conclude?
Mr. Chairman, only to say that I was justly admonished by our colleague from Ohio. I did go to Zell's yesterday in Northwest Indiana and have a chili cheese dog and fries to go, and I still am filled with self-loathing, but it was good. So I'm going to try to do better today. Thank you, Mr. Chairman.
And that high note,
thank all of you.
On that high note, we thank all of our distinguished presenters today. Thank you very much.
Thank you, sir.
Stand adjourned.
This is a handwritten message from the person. Was at a commander in the Arkansas Guard, just had a massive heart attack. So that message asks if the general would give him a quick call and try to cheer him up. So,
Phone number?
yes,
Okay.
everything's in it.
Okay, I'm
Thank
sure
you.
she's going to be happy. Thanks.